Yes, sir. We are on live, sir, and we are starting session, sir. So, very good morning, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for this wonderful webinar today. So, I would like to welcome the organizers of Ahmednagar Obgyn Society, and Shield Healthcare feels happy to join hand with this Ahmednagar Obgyn Society in providing this technical support for this webinar. I would like my pleasure to welcome the chief guest of honor, organizers, and chief speakers for the today's session. Without wasting time, I would like to hand over the session to Mrs. Karishma ma'am, who is going to be the master of ceremony of today's session. I welcome you, ma'am. I'm handing session to you, ma'am. Over to you, ma'am.
Thank you so much, Dr. Stalin. I would introduce and invite Dr. Bansi Shinde, President Ahmednagar OBGY Society, and Dr. Sonali Vahadne, Secretary Ahmednagar OBGY Society, organizers on the webinar dais.
Karishma, read the CV of Bansi, sir.
Yes. Dr. Bansi Shinde, MBBS DGO DNB OBGY, Consultant Gynecologist, Infertility, IVF Specialist, Laparoscopic Surgeon, Honorary President Ahmednagar Obstetric and Gynecological Society, Chairperson Scientific Committee AMOX Shady 2016, Faculty in State and National Conferences, Director Shinde Hospital and Ankur IVF, Ahmednagar, Maharashtra. Dr. Sonali Vahadne, MBBS DGO, Consultant. I'm sorry. Yeah.
Consultant obstetrics.
No, I thought somebody saying something.
No.
Okay, moving on. Consultant obstetrician and gynecologist practicing in Ahmednagar since 15 years. Honorary Secretary Ahmednagar Obstetrician Gynecologist Society. Scientific Committee member for AMOX Shirdi 2016. Special interest in RPL, infertility and coloscopy. Works for cervical cancer awareness and prevention. Conducting various camps and workshops. Members of NGOs Seva Peet, Rotary Club and Inner Wheel Club Ahmednagar. Awarded as COVID Warrior by Lions Club. Speaker for various national and local conferences. Now I would request Dr. Bansi Shinde to give his welcome address for this webinar. Over to you, sir.
Thank you, Karishma, for kind words. Good morning, all, on this warm Sunday. On behalf of Ahmednagar OBGY Society, we welcome all the seniors and the Stalwardi, the chief guest, Dr. Kanan Ellikar Madam, the guest of honors Vidya Thobi, Aminu Agarwal, the chief organizer and taking very good efforts, Dr. Rajendra Singh Pardesi and Ajay Manasse. Actually, this webinar on USG update will provide a lot of insights in doing USGs and the practical knowledge. Our chief guest, Dr. Kanan Ellikar ma'am, actually no words can explain her work, but in short, I can say she is the teacher of teachers. I welcome you, ma'am. Vidya Thobi ma'am, also a senior teacher, and again the same I can say she is also the teachers of teacher. Minu Agarwal ma'am, hardworking and consultant from POGS, the president-elect for POGS now. I welcome you, ma'am. Without efforts of Dr. Rajendra Singh Pardesi, this webinar would have not been possible. And sincere and hard work of Dr. Ajay Manasse, and I wish all the best for the grand success for Manasse sir. We look forward for a great webinar on USG updates. We have very beautiful and sincere and hardworking speakers, Dr. Ashwini, Dr. Prashant, and Dr. Prarthana Shah. I really thank Dr. Prarthana Shah for accepting our request on last moment for giving a talk. I welcome you all on this great grand Sunday morning, and I will ask Dr. Sonali to take further.
Thank you, Bansi sir. It's my great privilege. I welcome once again all the chief guests, speakers, organizers, and everyone. A very warm morning to all of you. on behalf of AMOX and Ahmednagar Obs Gynec Society. Now I would like to introduce our most active member who really participate and encourage us to organize many such educational programs. I would like to introduce Ajay Manasse sir. Dr. Ajay Manasse sir, he's a member of NIMC. He's medical legal consultant since 18 years, giving advice for free of cost. He's chairperson, official AMOX website. He's chairperson for Sexual Medicine Committee, FOXY 2014-16. He's also chairperson for Adolescent Health Education Committee, AMOX 2014 and 16. He had been joint secretary for AMOX. He's past president, Aurangabad OBGY Society. He's national trainer for FOXY Adolescent Health Committee. He had many publications, that is 9 national and 4 international publications. He's authored topic in various FOXY focus and various books. He's ex-superintendent MGM Medical College, Aurangabad. He's health advisor for Sports Authority of India. And he's charter president for Rotary Club of Aurangabad. I welcome you, sir, Ajay Manasse sir, and kindly welcome our chief guest.
Yes, thank you, Sonali ma'am, and thank you, Bansi sir, for giving me this opportunity. Thank you, Ahmednagar OBGYN Society. Now I welcome our chief guest, none other than Dr. Kanan Yelikar madam, who is a guiding and inspiring force for all of us, basically. Yes. So can I have the short CV of madam? Because if I start reading her CV now, it will take 10 minutes at least. It's such a long CV. Okay, very nice. Dr. Kanan Yelikar madam, she is rather was Dean, Government Medical College Aurangabad, now retired and given special charge by the Government of Maharashtra. And she has been awarded the prestigious Dr. B.C. Roy Award of Government of India, which will be a swapna for every teacher in medical field. And she deserved the prize. She is ex-professor and head of Department of OBGYN, Government Medical College and Hospital Aurangabad, during which in her tenure, the department has reached the height of excellence in the Government Medical College. She was Vice President FOXY in 2007. She was Chairperson Clinical Research Committee FOXY 2004, Organizing Secretary of 40th All India Congress of Obstetrics Gynec 2005 Aurangabad. Till today, we are holding the record of having maximum research papers and paper presentations, that is around 1,000. Till today, it is not broken by any conference. See, such a tremendous work done by her. She was president of IMOC 2016 to 18. Fortunately, I was her joint secretary there for 2 years. And then she was president Aurangabad OBGYN Society in 1998. And she was elected as a Senate member of the Maharashtra University of Health Sciences, Nasik in 2003. She is a member of Standing Committee MUHS, and she is advisor on various boards. She has got many prizes. She has presented more than 150 papers and research papers in various national and international level. A very huge work in academic and social also. I welcome Dr. Kanan Yelikar madam and request her to bless us. Kanan ma'am.
Very good morning to all the organizers, speakers, faculty members, and all my young aspiring obstetrician and gynecologists whom I am meeting for the first time, few of them. And of course, all my old friends like Dr. Rajendra Singh Pardesi, who is now heading towards the presidentship of AMOGS, and Dr. Ajay Manasse, also heading towards the vice presidentship of AMOGS and also in the FOXY also. And I wish them a grand success for the future. And Dr. Vidya Thobi, I have a very good news for you that you have become the president of Kasoga. So a Maharashtrian lady going to Karnataka and yes, proving herself. Really, it's a proud moment for all of us. And she is the alumni of Aurangabad Medical College. So more so, I'm proud of her.
Thank you.
And the Nagar OBGY Society, who has taken an initiative. I remember Dr. Bansi Shinde during the Shirdi AMOGS doing a lot of hard work. So most of you I know, and I'm really proud of all of you. And I am really happy to see the progress. None of you have stopped at any of the steps. you are going further and further. So that is your individual progress. I'm happy for that. Coming to the today's webinar on updates in ultrasound. Ultrasound is such a subject that it really needs update every now and then. In 1964, Ian Donald was the first person to introduce ultrasound in obstetrics, and I'm proud that obstetricians were the inventor of ultrasound rather than the radiologist. So we should be proud that we are the inventor and we are the user, and we should use it in the proper sense. Beginning with the linear scans, now we are going towards the 2D, 3D, and 4D. And I think one day will come when we will start with the histo ultrasonography. That is the histological picture of any organ, any tissue. That is the future of ultrasound. And in obstetrics, as Dr. Ajay Manasse is very thorough in the medical legal issues, everybody is afraid of keeping an ultrasound machine, keeping the records. You never know when you go wrong with it, and you are just caught when you are unaware of it. So those little tips Ajay Manasse is going to give us. And lastly, I would like to request all the sonologists to be really, really ethical in its use, so that the few black sheep in our profession and people keep on pointing on the same issue when you go at the government level and discussing certain things, they will say, तुमचेच doctors असे आहेत madam, तुमचेच doctors हे काम करतात ना, मग आम्हाला असंच राहावं लागतं. So that stigma which is there because of few doctors, it should go in the coming future. And I wish this webinar a grand success, and also thank the organizers for remembering the past old persons like me to be a part of your webinar. Thank you so much.
Madam, thank you very much, madam, for your blessings, and we never forget you, because we are here due to you only. That is the best point of our life, basically. So how can we forget that? Okay, now we move on to thank you, madam. Thank you very much for the blessings. Now we move on to the sorry, guest of honors. And the first and foremost guest of honor is Dr. Vidya Thobi. As madam said, a Maharashtrian lady going to Karnataka and winning there and having a presidency of Karnataka after Shivaji Maharaj. I think she is the second person who went to Karnataka from Maharashtra and conquered there. So congratulations, madam, for that. She is a professor and head unit Department of OBGY, Al-Amin Medical College, Vijayapur, Karnataka. She was chairperson, Food and Drug and Medical Surgical Equipment Committee, FOXI 2018-20, and got a Best Committee Award, Meru Darahan Sutia in 2020. She was ICUG Governing Council. She is ICUG Governing Council member 21 to 23. Then FOXI Champion Award 2019 she got. Then she was National Corresponding Editor Jogi, Organizing Chairperson Kasoga 2016, then President Bijapur OBGYN Society in 2009. She was Secretary Bijapur OBGYN Society 2007. Then publications in various books and contributions to FOXI, focus and speaker at national and international conferences. More than 100 publications she is having. Papers at national and international conferences. Original research papers at least more than 65, I know. And organized various CME workshops and awareness programs at various levels. She was advisory faculty of boards of Rajiv Gandhi University of Health Sciences, then postgraduate and undergraduate teacher for 30 years, more than 30 years. So I welcome Dr. Vidya Thobi, madam, and request her for the word of blessings.
Thank you, Dr. Ajay and Dr. Pardesi and the organizers of this webinar. It is a very great webinar which is focused on ultrasound updates. I acknowledge and my respect to Dr. Kanan Yelikar, and I always remember her. Because of her only I stepped into FOXI, I must say. I always admire her leadership. In 2005, actually, we witnessed her grand conference at Aurangabad. So from there only I got inspired, and because of Dr. Pardesi, I stepped into Foxy and I contested for the Food, Drugs and Medical Surgical Equipment Committee of Foxy, which he was chairperson earlier, and he also guided as a vice president during my tenure. So I must thank him. I thank Dr. Shinde, Dr. Sonali. I am seeing Dr. Josna Dole on screen also, and I actually participated in one of her webinars as well. There are so many members of Ahmednagar OBGYN Society and others who have joined. As well, I must acknowledge the presence of Dr. Meenu Agarwal, who was also co-chairperson along with in my tenure, and she did really wonderful programs. The certificate course which she designed, and actually so many people wanted to join, but it was closed. So I expect many more programs of Meenu Agarwal during her POGS and in further also. I congratulate her. So about these ultrasound updates, I must say that this is ultrasound is such a boon or bane, whatever we must say, that always it is a operative dependent. So we have to brush our knowledge every now and then, as Yeligar madam told, that it changes. And as the advances they take place, we also should know about the limitations of this ultrasound machine and where to use it. Now the interventional things have come for various congenital anomalies we can do, and also we know in various RH incompatibility or any intrauterine transfusion, we always now and here and there we use this ultrasound. So I congratulate the organizers, and let us look forward the inputs from our faculty, Dr. Ashwini and the others on ultrasound. Thank you very much for inviting me, and I always be there for Maharashtra. I always wish a success to Dr. Ajay Manasse, and we have given already, we have supported him in all his tenures. Thank you very much.
Thank you. Thank you, Vidya madam. Having blessings from great lady,
just a
from
minute.
Karnataka.
I just forgot to mention the name of Dr. Meenu Agrawal and Josna Dole. Dr. Josna Dole and we have really worked very hard during the Shirdi Amox conference. Josna, sorry for that.
No,
Sure.
madam.
Thank
Good
you.
morning, madam. Good morning. Nice to see you in the morning.
Yes.
Yes. Josna madam is basically from Aurangabad and now working in Ahmednagar. So both ways she is related to this webinar.
Yes, yes.
Yeah, yes. Can I have a CV of Meenu, please? Again, a great lady from Pune. Yes, she was chairperson Imaging Science Committee Foxy 2018 to 21. Just now finished her tenure. Then she is national director, clinical board, Morpheus IVF. Then elected executive board member, Asia International Society of Gynecological Endoscopy. Then course director, international training course in UAE and at American University of the Sharjah. Visiting consultant at JTS Medical Center, Dubai, UAE. More than 10 publications in international journals. Authored 4 books as first author. Then Bachelor of Reproductive Surgery, European Board Certified Awards. India's Greatest Leadership by Asia One. Then second award is Icon of Health by Times Group. Then Inspiring Gynecologist of West India by Health World. And then Champion of Foxy by Foxy, and many more, but she has mentioned only 4. Great lady, great academician from Pune, our very dear and near friend, Dr. Meenu Agrawal. I request her to bless us for the webinar.
Yes. Good morning, everyone. Thank you, Dr. Ajay Manasse, for this beautiful introduction. And it's always a pleasure to be both with Aurangabad Society as well as with Nagar. So I'm somehow, Nagar is a very, very versatile, very vibrant society. So I'm very happy always to be either in Nagar or both in Aurangabad. And with Pardesi sir and with Dr. Ajay Manasse, and it's always, whenever I've been there personally, Vidya Thobi madam and myself, we were together in Aurangabad. So it's always a very, very good experience. And this ultrasound conference which you have organized, webinar. I think it is a need of the hour. All gynecologists may not be doing their ultrasounds, but they should know the basics of ultrasound. They should know, that we have now reversed the pyramid, so we can pick up most of the anomalies in the first trimester. So the less work for you than Dr. Ajay Manasse, because less legal complications if we pick up early and we decide whether to continue or not to continue. And it's a great feeling to be on the same platform. Also, very nice to see Kanan Yelikar madam, and always words of wisdom from her. She is very grounded, that yes, doctors should not be doing, something which is not by law, permitted by law. So all that we must always keep in mind. Ultrasound is our third eye. We have to be vigilant. We should do whatever is required for the patient. But however, we should keep in mind that everything should be done within the law framework. That is very important. Not that even if you're not doing something wrong, you have to make sure your PCP and DT certificates are all in place. Whatever it has to be displayed should be displayed. So all those things you must keep in mind before starting your ultrasound machine or center. So thank you very much. And Dr. Ashwini Kale and other speakers, I'm sure we are going to have a great Sunday morning learning for everyone. So thank you, and good blessings and lots of best wishes to you, Dr. Ajay, for your elections as well. And I'm sure you are a sure shot winner. So not to worry. Thank you. And Pardesi sir, many, many thanks. It's always a pleasure to talk to you and to connect with you in virtually or in physical. Thank you so much. Thank you. And Vidya Tobi madam, ultrasound course we are starting now. The third season is starting from 1st of March. Lots of queries were there and people are happy with this course. We actually spent a lot of time making the scientific program. So this scientific program is very strong, and whoever wants to register should do it fast, because first 500, 450, then we are going to stop it. So, so others, I mean, you can go, you are receiving messages from Foxy. So just go on the link and register yourself for this course. Thank you very much. Thank you, and wish you all the best for this. Dr. Bansi and Dr. Sonali, wish you all the best for this webinar. And Jyotsna, thank you.
Yeah.
Thank you, Dr. Minu, for those kind words. And now we move on to the our own guest of honor, who is always a backbone, rather ek khambi tambu, we can say in our.
It's okay, Ajay, it's okay.
Don't walk sir. He has presented. He is incoming president of AMOGS, and he is ex-vice president of Foxy, and presented 27 papers in 20 national and 7 international conferences, and 6-time best paper award in Foxy, the highest award winner. And so many things to tell about him. A real true academician, best person, humble fellow, my mentor, and whatnot. Anybody from India can go to him for anything, and he will help her or him. So he's Ajat Chatru Manus in Foxy. Ajat Chatru means no enemy in Foxy. He do not belong to any group, and he is such kind of person. So I welcome Pardesi sir and request him for the blessings.
Thank you, Dr. Ajay. Congratulations, Ahmednagar OBGYN Society, for organizing such a nice webinar. And thank you, Dr. Vidya Thobi, Dr. Minu, and all the chairpersons and faculties for gracing this webinar. And lastly, because it's a special thanks to Dr. Kanan Yelikar madam, she is our guiding force and she is mentor for gracing this webinar. So, Dr. Ajay, I think there will not be any problem for you if President-elect of Pune, Dr. Minu Agarwal is with you, and President-elect Kasoga, Dr. Vidya is with you, and Josna Dole, our chairperson AMOGS, is with you. So I don't think there will be any problem. I don't want to become in you and scientific content. I wish every success to this webinar and success to Dr. Bansi Shinde and Dr. Sonali Wahadne's work, and they are doing really excellent work. Thank you so much. Thank you, and continue. Okay. Thank you.
Hello.
Thank you. Over to Sonali.
Thank you very much, all the chief guest and guest of honor, for your encouraging and words of wisdom. I really give you my warm welcome to all. because you are spending your leisure time for this academic feast. So actually everyone should be congratulated for that, for giving their wonderful Sunday for academic feast. Thank you, Ajay Manasse sir, for introducing our chief guest. I now move forward with introduction of the chairpersons. May I have the CV of Dole ma'am? It's my great pleasure to introduce our own dynamic, charming personality who is equally intelligent IV specialist, Dr. Josna Dole madam. She is obstetrician and gynecologist and infertility specialist practicing in Ahmednagar since last 30 years. She has started her first IVF center at Ahmednagar district in year 2004-05. She had been past president of AMOX 2016, organized at Shirdi. She was also former president of Ahmednagar OBGY Society in year 2017-19. She was also awarded, got the Best Gynecological Society Award under her leadership in the year of 2018. She was also former president of Oncology Committee for AMOX in the year 2018-20. She is currently a president of Reproductive Tract Committee Infection of AMOX. For her social activities, she had got District Mahila Award by Madhurangan Sakal and Sarvamat in 2017. She had been awarded by prestigious Wonder Woman Achiever Award in the year 2020. So very warm welcome and good morning to Dole ma'am.
Thank you, dear Sonali. Thanks for nice introduction.
The second chairperson for today's webinar is Dr. Varsha Dole madam. She is a state supervisory board member of PCPNDT. She is president-elect for Nagpur OBGY Society 21-22. She had been past vice president IMA Maharashtra State. She is past president of IMA Nagpur. Then she had been awarded by various prestigious awards, that is NOGS Gold Medal in 2017 as a Best President IMA National Award, Best Secretary for IMA, recipient of National Award of IMA, Best Editor for Intimate Souvenir of IMA, and Best All-Female Team of IMA. So grand welcome to you also, ma'am. Varsha ma'am.
Thank you.
Welcome for today's webinar.
Thank you so much.
There is one change. Actually, we had Dr. Pratna Shah as a third chairperson, who will be now a speaker for our third topic. Sir, should I introduce her while her talk, or should I go forward with her introduction?
No, at the time of talk.
Okay, sir. Okay. Now we'll be starting with our today's webinar topics. To enhance our knowledge on improving IUI results, we have our first eminent speaker, who is an IVF specialist, Dr. Ashwini Kale madam, who is also chairperson for Young Talent Committee, AMOX. Madam Ashwini Kale is IVF consultant and chief embryologist at Asha Kiran Hospital and Asha IVF Center. She is general secretary POGS for year 2021. She is chairperson AMOX YTP committee for year 2022. She is a treasurer Maharashtra chapter Ussr for the year 2018 and 20. She is zonal coordinator for AMOX 2016-18. She is peer reviewer for JOGI for year 2016 and 18. And she is assistant professor for BJ Medical College, Pune. I welcome you, ma'am, for today's talk.
Thank you so much. Thank you so much, madam. It's really homecoming to give this talk today on a Sunday morning. Respected Pardeshi sir, Yaikar madam, Vidya Thobi madam, Meenu madam, Ajay sir. It's really a pleasure to be here, and thank you so much for inviting me. I'll just share my screen. Yeah.
Ashwini,
It
is not full screen.
Yes, sir. I'm just putting it on.
Yeah. Now done. Great.
Okay. Yes. Thank you, sir. So, how to improve IUI results is what I'll be speaking on today. In a country like India, IUI is still a first-line treatment option because it is easily accessible and it is still affordable for the Indian pockets, and it can be practiced widely. But now with coming of the new ART Act and bill, we are still not sure that which center will be recognized as an IUI center and who can be doing IUI and all. But as far as it's concerned till now, there are many people who practice IUI wherein you can get the semen prepared from outside and still do it in your setup. It is well accepted because it is still a very simple procedure as compared to IVF. Though NICE had written over IUI over IVF long time back, but still the data is very biased regarding this. Now coming to improving the results, I would like to start with right from counseling of the patient to indications to the various stimulation protocols which can improve or change your results. USG monitoring of the follicle and endometrium, which plays a key role on deciding the timing of your trigger. Then deciding the type of trigger, semen analysis and semen preparation, how it makes a difference in your IUI results, to the timing of IUI, whether there's any role of any adjuvants, and finally the practical tips. So starting with counseling, it is very, very important to counsel a patient who's going for IUI in your routine day-to-day practice, because when you tell a patient after many timed intercourse and all that you need an IUI in this cycle, he feels that you're doing some magic for him and it's going to give him 100% pregnancy result. So we have to tell him that IUI doesn't equal to 100% pregnancy result. We have to give him a realistic picture of the results. Also explain to them the procedure in details as to how many times they need to visit, because as the frequency of visit starts increasing with your follicle monitoring, they may just decide to drop out in between, and this also reduces the IUI results. Then a success rate, which has to be very realistic. The success rate of IUI worldwide is only 10 to 20%. It has not yet increased, but then to achieve this 20%, there are so many multiple tips which if we follow, we can definitely achieve this 20%. Consents are very important, and explaining the cost to the patient is very important, because there may be times in IUI where you may decide to just add on gonadotropins, and this may add to the cost of the treatment, where the patient initially would have thought that IUI is just a procedure where there is only procedure cost. They may not be aware of the cost that goes in with the gonadotropins. So that should be clearly mentioned at the start so that the treatment continues well. Now coming to the age of the patient, we all know that the maximum success rate is achieved in less than 25 years, where the maximum conception occurs when the age of the patient is less than 30 years. So always feel the sooner the better the results, rather than keep on trying timed intercourse with just the follicle monitoring. Maybe giving them a cycle of IUI would improve the results by 10 to 20%. Number of cycles. Now, how many cycles of IUI are to be done? Though NICE says that not more than 3 cycles, we still practice 4 to 6 cycles of IUI. But mind well, all these cycles should be good stimulated cycles with a timed IUI is to be done. The cycle fecundability, as we all know, decreases by half to 2/3 thereafter, because with every cycle, the result keeps on decreasing. There's about 88% result within the first 3 cycles, and within first 4 cycles, it would be 95%. But as you move on to the 5th and the 6th cycle, the result keeps on decreasing instead of increasing. Now, selecting the right kind of patient for IUI also changes your result drastically. When you have patients who have unexplained infertility, though now ASRM and fertility studies say that they should directly go in for IVF, but in our country, we still give them a chance of IUI. Patients with mild cervical factor infertility and ovulatory infertility like mild PCOS, donor IUIs, mild male subfertility, and those patients with ejaculatory disorders, they have got good chances when an IUI is done as compared to a timed intercourse. Poor results can be seen when patients have severe male factor, but still the patient insists on doing an IUI instead of going in for a further treatment of ART like IVF or ICSI. When patient has tubal factors, when they are pelvic adhesions, severe endometriosis, and severe PCOS, these patients are those in whom IUI may not give that good a result as an IVF would have given. Now coming to stimulation protocols for IUI, there are multiple and n number of stimulation protocols. But the thing that has to be considered whenever any stimulation protocol is to be started is what kind of a region where you practice in, whether the cycle can be monitored or not, whether it is cost effective for your patient or not, and selecting the right kind of treatment for the right kind of diagnosis. Like if you have a patient of anovulatory PCOS, these days letrozole is the drug of choice. So you can start the ovulation with letrozole. Any kind of protocol that suits either the step-up protocol or the extended protocol, anything would work well. Now, adding gonadotropins to this letrozole cycle definitely improves the follicular output. It also reduces the dose of gonadotropins that are needed when you are doing it with letrozole. So we have to weigh the benefit versus risk when we are adding gonadotropins. And mind well, whenever gonadotropins are started, always start it when they are indicated, not as a blanket procedure. Like even if you're getting follicles with letrozole, still you want to add gonadotropin to get those extra 2-3 follicles, it wouldn't improve your results. Start with the lowest possible dose, and whenever gonadotropins are started, you have to monitor the cycle with ultrasound. It cannot happen that gonadotropins are started and the patient would visit once in 3-4 days. It has to be a monitored cycle. Check for the previous cycle for a response, whether the patient has got a good response with only letrozole or oral ovilogens or only with gonadotropins, or what was the dose that was used in the previous cycle, so that you can plan this cycle very well with gonadotropins. And gonadotropins, once started, they're always given daily, as the aim is to achieve basically 2 to 3 good follicles. Coming to adding of antagonist in an IUI cycle, basically antagonists are added to prevent the premature LH surge, which is commonly seen in patients of PCOS, and this results in cycle cancellation. So LH surge is basically required for absolute luteinization, the final oocyte maturation and follicle rupture. The main signal is nothing but progressive increasing in estradiol, which is due to the formation of the dominant follicle. There are about 20 to 25% of patients who suffer with this premature LH surge. So antagonist can be added in an IUI cycle, but it definitely doesn't improve your pregnancy rates, but it prevents the premature LH surge. So you have to weigh the cost versus the benefit of adding an antagonist in an IUI cycle. It can be either a fixed or a flexible protocol, but there is a cost which comes with the antagonist cycle. Coming to Usg monitoring, which is the most integral part of doing an IUI, it is your follicle monitoring by ultrasound, and the second is endometrial Dopplers. Always do the scan yourself because it definitely improves your result. It makes a lot of difference in your practice when you see it for yourself, right from day 2 to day 5 to day 7 to deciding on the day of trigger. And it is also convenient for the patient when everything is just done under one roof. Otherwise, the patient does a scan from some other center. You are stimulating the patient and you are going to take the patient again to a third center to do an IUI. So all these things hamper the IUI results. So doing the follicle Doppler is very important to decide the day and the time of the trigger. Ideally, a mature follicle shows about 3/4 of the vascularity. That is, the 3/4 of the follicle has a good flow, and the PSV is always to be more than 10. When you have a PSV of around 11 to 12, that gives a good pregnancy because it indicates that it's a mature follicle. Then rising PSV and a steady low RI indicates a good mature follicle. This all predicts good results. There have been many studies which shows that whenever a PSV is more than 10 to the range of 10 to 12 before HCG, that is about 12 hours before your HCG, this is a good follicle and ultimately would result in pregnancy. A 3D gives you a more accurate tool for the volume assessment. So use the 3D probe also very frequently. You can actually see a cumulus in 3D also, wherein you can decide the time of your trigger. And the second tool to be used is your power Doppler or your color Doppler. So this is how an follicle image which is mature looks on a 3D ultrasound. Here you can clearly see the cumulus also. So this indicates that this is a mature follicle and it is the right time to trigger it. The doses of gonadotropins are also decided by the color Doppler parameters. There are patients who would require high doses, other ones who have a low ovarian volume, that is less than 3 cc. This can be very well assessed by a 3D ultrasound. Then patients who have less than 3 antral follicles on day 2 or day 3 of their scan. When the ovarian RI is more, that is more than 0.5, the PSV is less than 5 centimeters, the stromal flow index is less than 11. So all these patients are those who would require your high doses of gonadotropins, and maybe it could predict lower results also. Coming to perifollicular vascularization, the perifollicular vascularization should be grade 4, that is at least more than 50%, which predicts the maturity of the follicle. Coming to the endometrium on ultrasound, this is an equally important parameter that is to be assessed right from your day 2 till the day of your trigger. As we all know that peri-ovulatory period, the endometrium is around 6 to 10 mm and the secretory phase endometrium is 8 to 12 mm. So a day 2 scan is very, very important. Why? Because you have to assess the antral follicle count of the patient to decide the type of stimulation that is to be needed and to predict the stimulation. Because if you see a lot of antral follicle counts, if she is a typical PCOS patient, so you would know that you have to use lower doses of gonadotropins or oral ovulogens, and this would definitely give you better insight into prediction of OHSS. The second thing to assess on day 2 is to see for the endometrial thickness, see whether the endometrium is regular or if there's any irregularity in the endometrium, because that will predict how the endometrial thickness is going to be or how the endometrium is going to respond to your stimulation. And a good 3D scan on day 2 is also important to see for the structure of the uterus, to rule out septate, arcuate, bicornuate uterus, whether they are small fibroids, adenomyosis, so that it gives a clear picture that whether this patient is going to go for stimulation in this cycle or not. So this is how the proliferative triple line endometrium looks as it starts growing from day 7. This middle layer is basically the lumen, and then you have the functional layer, and the last one is your basalis layer. And if you divide this into zones as per the endometrial and periendometrial flows, so ideally the Doppler should go up to zone 3, zone 4, and which predicts a good result because that is predictive of good vascularity and a good functional endometrium. This is the Applebaum USSR scoring, which is basically uterine scoring system for reproduction. It measures the endometrial thickness, which gives a good score of 3 and 2 when the endometrium is between 7 to 14. Mind well, even an endometrium which is more than 14 is not a good score or not a good predictor of pregnancy. The endometrial layering should be a distinct 5-line appearance. The endometrial notion or the contractions should be more than 3. The uterine artery Doppler, as we see, the PI should be less than 2, which gives a good score. The endometrial blood flow should be in zone 3, which should be absent. And the ideal score of this Applebaum scoring is 20. So when you have a score of 20, it means that it's going to result in a pregnancy of about 97 to 98%. But there are very few times that we get this exact score of 20, but even a score of 16 to 18 is a good predictor of pregnancy when you do this scoring. Now coming to how thick is too thin, basically there is no clear-cut cutoff for a thin endometrium as to when an IUI should be cancelled. So basically even they have done IUIs in patients who have got endometrium of 4 to 6 mm and few have been pregnant. So till date there is still no clear-cut guidelines or evidence which says that this is a thin endometrium, and hence there is a role of doing a Doppler. Even when you see a thin endometrium, always put in a color Doppler and at least see how much is the vascularity of that endometrium. There is an association between endometrial thickness and pregnancy outcome. When the peak endometrial thickness is basically between 8 to 10 mm, it has given good pregnancy rates. So they know that when the pregnancy can be good, but there is no clear-cut lower limit cutoff wherein an IUI should not be done. Now coming to the type of trigger. So when is the ideal time when you give a trigger? So you can always trigger a follicle when the dominant follicle reaches 18 to 20 mm after assessing the follicular endometrial synchrony when you are using gonadotropins. When the patient is on oral ovulogens like clomiphene or letrozole, you can wait till 20 to 22 millimeters. And evidence still says that there is no difference on what kind of a trigger you use, whether it is a recombinant HCG, urinary HCG, whether you use only 5,000 international units of HCG, 10,000 unit or 5,000 combined and then give it, it doesn't make any difference. Timing of IUI. So this is very, very important because a timed IUI, even if you do it once, is going to give you a result of 18 to 20% as against doing a double IUI or an untimed IUI. So hence, because you have to time your IUI, you have to time your trigger. And how do you time your trigger is when you do a Doppler of your follicle and the endometrial Doppler as well to see whether it is in the implantation window or not. A single well-timed IUI makes a huge difference. So how do you time it? You can either do it 36 hours post your HCG trigger or 12 hours post LH surge if you are using the LH kit. Even a well-timed 12-hour IUI, which is done after your trigger, gives you good result if you have seen that the vascularity of the follicle is about 3/4, the PSV is more than 10, and the RI is less than 0.5. Now, coming to the male partner, the semen analysis plays an equally important role in predicting IUI results. The semen analysis should always be done in a standardized lab or maybe your own lab, because you have a clear-cut picture as to what is to be done of this semen analysis. Generally, there are many reports which just says that it's an OATS or oligoasthenoteratospermia, but you have to actually grade it as mild, moderate, severe, so that you have a clear-cut idea of whether you are going to do an IUI for this patient, whether you are going to take up the patient for IVF ART, or is it going to be an ICSI. Hence, that is why getting a very detailed semen analysis report is important. And the most important success factor to decide whether you're going to go for IUI and this count, even if it is low, it is going to give result, is your total motile sperm count, that is TMSC, which in a native sample to get good results in IUI should be between 5 to 10 million. There are various cutoffs in various labs. I generally take a cutoff of 10 million, but even a 5 million native sample TMSC gives you good results. And in a prepared sample, it should be around 2 million. It is nothing but it is a value which tells you that how much motile sperms are there in that sperm concentration. Coming to DFI, this is a very good tool which has recently come up. Though routine use is not indicated, it should be done in very, very indicated and limited cases as to patients who've got previous failed IUIs despite having a good follicle, good endometrium, and a good semen analysis. So these are the ideal candidates where you can do a DFI, and you at times, many a times you find that these patients have got a higher DFI of more than 30%. So maybe you can put these patients on antioxidants and try doing an IUI after 3 months. Previous cases of miscarriages, or in cases of mild to moderate OATS, where you see that the count motility is good enough to do an IUI, but when you do a DFI of these patients, that is DNA fragmentation index, you find that it is very high. So it is an ideal time that you switch over to some other treatment or put the patient on antioxidants. Semen preparation techniques, does it make a difference? Yes, it definitely makes a difference, because as per the sample, the technique has to be separate. If it is a normal sample, even a swim up method is fine enough to give good results. But when you see that the sample has mild to moderate oligoasthenoteratospermia, doing a density gradient definitely gives you a good motile post-wash count, which ultimately results into pregnancy. Sample collection is very, very important. Here, counseling plays a role, because the patient has to understand that he has to come and collect the sample in the hospital. And whenever the sample is collected, it has to liquefy within 30 to 45 minutes to be labeled as a good sample. And once the preparation of the sample is done, it is advisable to do an IUI within 1 hour of prepared sample. This also makes a huge difference, because the motility of the sperm is highest within that 1 hour of preparation. And as time passes by, reactive oxygen species, or the DFI of the sample, of the prepared sample, goes on increasing. Many a time it happens in a busy OPD that patient has come and given in sample, it is prepared and it is just lying like that because the OPD is going on. You may feel that this can be done after 20-30 minutes or after about 2 hours, but mind well friends, that 1 hour really makes a difference, because we know that already the results of IUI are only 10 to 20%. So just making these small changes may just alter your results. And if whenever you get the sample prepared from outside to do an IUI in your own setup, always make it a point to see for the post-wash sample with your own eyes under your own microscope to be sure that it has the same count and motility as is written on paper. Coming to the actual procedure of IUI, it should be atraumatic. The pushing of the sample should be very gentle. It should not be too fast. You should avoid using tenaculums and dilators when you're doing the IUIs. Exception to this can be very difficult negotiations. If bleeding occurs during doing of an IUI, so basically that just says that your results are definitely hampered, because it starts uterine contractions, and it should not happen. This generally happens when you're trying to negotiate a very closed or a tightly stenosed os. So at times, if the patient has come in for a second cycle of IUI, you can always have a look at the previous cycle if you have made a note that it was a difficult IUI. At times, it is just the anteverted or the retroverted uterus, or the position of the uterus, because of which it may be difficult. If gentle filling of the bladder or if slight negotiation can help in this, you can avoid the trauma. If the sample gushes out, so this means that you have put in more than what the uterine volume was, and that is why it has come out. The second thing that may happen in an IUI is the patient may start getting abdominal cramps. So that is not a normal thing. It is basically the sample preparation is faulty because it has got anti-inflammatory agents, which has caused this pain and cramps in the abdomen. And there is evidence that IUI with COH increases the live birth rate as against with IUI alone. Pregnancy is increased with IUI versus timed intercourse. And there is enough evidence to prove that whenever you have an absence of ovulatory dysfunction, that is, the female ovulatory pattern is absolutely normal, just monitor the cycle. A natural cycle IUI works well. There is no need to stimulate a cycle despite of a good ovulatory function. And a timed IUI is very important, which COH gives better result than natural cycle IUI in the absence of female ovulatory dysfunction. So why this timed IUI is important? Because there are many clinics in the West which do not work on weekends, or even in metro cities these days there are clinics which do not operate on maybe Sundays. So if you have to time this IUI accordingly to get good results, you have to know when you're going to trigger the patient and whether IUI is available on that day or not. I feel that making these minor changes and leaving the attitude of main jhukega nahi would definitely give you a good success rate of 10 to 20%, even with an IUI. Thank you so much.
Yeah, great reference from Pushpa. Thank you. Thank you.
Thank you, dear Ashwini ma'am, for your lucid, elaborative talk. Now I would like to request Josna Dowle madam to kindly give her expert opinion.
Yes, very, very nice and elaborative lecture, Dr. Ashwini. You are fantastic, really. When I hear you now, I always remember Erika madam. You are replica of her.
Thank you so much.
Yes, yes. Ashwini has explained all the factors very well. Basically, the few points to be remembered. The important thing is good stimulated cycles and timely IUI improves the result. That is very important. The factors which gives poor result to IUI should be considered, and that factor should be explained. Nowadays, PCPNDT Act and this consumer protection, patient complaints everywhere. So proper counseling is very important, that Ashwini has explained very well. As she has said, letrozole and addition of gonadotropin improves the result. And in some cases, addition of antagonist improves the result. And the most important things which Ashwini has explained very well is follicular Doppler and endometrial Doppler and vascularity. So if we follow these things, it definitely improves the result. If we give this, if we go for this Doppler and give HCG, that is trigger, and ask patient for timely intercourse, that also improves the result. So considering all these small point is very important. Ashwini has explained everything very nicely. So thank you, dear Ashwini. Thank you so much. Thank you, Pardeshi sir. Then Ajay Manasse, all the team of AOGS. Thank you so much for giving me this opportunity, and all the best to Dr. Ajay.
Thank you so much, dear ma'am, for your words of wisdom.
Thank you. All the best, Ajay sir.
Thank you.
We are waiting for a bigger party from you at Aurangabad.
Yes. And we'll join for the party.
If you, you all are going to help me, and then it will be a great party. From
we are there.
Thank you very much. Sonali ma'am.
Okay. So to enlighten us on talk on first trimester scan beyond knuckle translucency, I would like to invite our second speaker, who is a fetal medicine consultant at Aurangabad, Dr. Prashant Asegavkar sir. He is director and consultant in fetal medicine at Garbhangpur Fetal Medicine Center, Aurangabad. He is fellow and ex-consultant in feto-maternal medicine, CIMAR Kerala. His FMF UK certificate of competency in 11 to 13 plus 6 week scan, then fetal abnormalities and Doppler ultrasound. His areas of interest are first trimester USG scan and screening, fetal invasive procedure and interventions. He is member of International Society of Ultrasound in OBGY, ISOC, and International Society of Prenatal Diagnosis. He had various publications for his honor. Why obstetric patients are admitted to intensive care unit, and pregnancy outcome in women with pre-eclampsia remote from term in rural tertiary care center volume. So I welcome you, sir, for our next talk.
Am I audible?
Yes, sir.
Thank you, Sonali ma'am. Thank you for kind introduction. First of all, I would like to thank Ahmednagar OG Society, Dr. Pardeshi sir, Mane sir, for this wonderful opportunity to present my work here. And it's really a great honor to have respected Yedikar ma'am as the chief guest of this webinar. And thank you all the Foxy office bearers, Meenu ma'am, Toby ma'am, and rest of the panelists, and particularly Varsha Dhawale ma'am. Varsha Dhawale ma'am, I don't know whether you might be remembering me or not, but I have seen you working actively in the Nagpur OG Society since my PG days. And it's really fortunate for me to have you as a chairperson for my talk.
Thank
Is my screen visible?
No, sir.
No, sir.
Now?
Yes, sir. Can you please go to slide? Yes, sir. Perfect, sir.
Is it visible now?
Yes, sir. Yes, sir.
Yes, yes, full screen. Perfect.
Okay. I'll start now without wasting any further time. So my topic for today is first trimester ultrasound, which is my topic very close to my heart. I have named it Beyond NT, but that doesn't mean that I will not include NT or related things in my talk, because NT is a very much integral part of first trimester ultrasound. I'll just take you through the real case-based scenarios and real images and cine loops, rather than going into much of embryology and anatomy. I know many of you might get bored with the theoretical part, so I'll just give you case-based approach and what fetal medicine consultant can help you with all these cases. So what is the current goal of first trimester ultrasound? Current goal of first trimester ultrasound is, main goal is aneuploidy screening, which is performed in a standardized manner and in accordance with the protocols laid down by Fetal Medicine Foundation, UK, by respected Kypros Nikolaides. Then current goal is for not only for aneuploidy screening, but for fetal anatomic assessment also. You have to assess the structural, you have to do the structural evaluation of the fetus also to detect major fetal malformation. I'm not saying that you have to detect all the abnormalities at NT scan itself, but the major or early severe structural malformations which are always detectable should be picked up at the time of 11 to 13 weeks 6 days scan, and to offer diagnostic invasive modalities for genetic workup in relevant cases wherever possible. So this is one image I would like to focus everyone on. So by obtaining this proper mid-sagittal image, in the mid-sagittal section, this is the crown rump length of the fetus, maximum information of the fetus can be garnered in this single image. Then this is the section depicting, mid-sagittal section depicting the nuchal translucency, in which all the midline brain structures are seen. Nasal bone is seen nicely, and nuchal translucency, thin nuchal membrane, and amnion is seen separately. So these are the normal images which you have to acquire at the time of your nuchal translucency scan. That is nuchal translucency, then nasal bone, then ductus venosus, and whether the fetus is having tricuspid regurgitation or not. So these 4 are standard images which should be an integral part of your first trimester ultrasound. So coming to the cases, I'll like to present cases one by one. The first case is young primigravida aged 21 years. But she is married since 4 years. Early marriage, non-consanguineous marriage it was. And she conceived with ovulation induction followed by IUI. IUI was very beautifully elaborated by Ashwini Kale ma'am in her talk. So at peripheral center, it was a timed IUI, and she got conceived with the help of the IUI. So she presented at 13 weeks, 5 days of gestation, and ultrasound. What ultrasound revealed is one of the fetus is having raised NT, unossified nasal bone, ductus venosus A wave reversal, as well as tricuspid regurgitation. I consider myself very fortunate enough because I have found all the 4 major aneuploidy markers of the Down syndrome or trisomy 21 in a single fetus, and not even a single fetus. That also DCDA pregnancy with 1 fetus was affected by all these 4 markers. Then I did systemic structural evaluation of the fetus, but it did not reveal any major structural malformations at this stage. Then co-twin was found to have normal aneuploidy markers, normal NT, well-ossified nasal bone was seen, normal ductus venosus flow was there, and there was no tricuspid regurgitation. And early structural survey was also normal for the co-twin. So these are the images of normal versus abnormal. You can see the normal twin is having normal appearing nuchal translucency, whereas abnormal twin is having raised nuchal translucency. And you can clear-cutly see the unossified nasal bone also. These are the images which are pardon me. These are the images of both the fetuses. One is having normal nuchal translucency, other one is having nuchal translucency of 4.4, which is more than 99 centile for this CRL. Unossified nasal bone, ductus venosus reversal, and tricuspid rigor. All 4 markers present in 1 fetus. It was a DCDA twin gestation. These are the magnified images of the same aneuploidy markers. Then in such a case, what to do next? So question arises. But before proceeding for any intervention, we have to do invasive fetal diagnostic procedure, that is chorionic villus sampling for both the fetuses to obtain chromosomal microarray, and followed by selective fetal reduction after due risk consent. So this is the ultrasound cine loop of chorionic villus sampling. In the anterior placenta, one placenta, the healthy fetus was having anterior placenta, and abnormal fetus was having posterior placenta. I have deliberately included videos because though it may look simple that needle is going in and coming out, but in practicality, CVS in posterior placenta is much difficult than other interventional procedures, according to my guide, respected Dr. Bijoy sir. So after chorionic villus sampling, we decided not to wait for the results of the chromosomal analysis because all the 4 markers were present, and we proceeded with the fetal reduction of the affected fetus. As it was a dichorionic diamniotic twin gestation, we used the intracardiac potassium chloride injection. We instilled 1 cc of the potassium chloride injection into the fetal heart of the affected fetus, and we achieved the fetal reduction of the affected fetus. So after reduction, this is the drop down sign of the fetus. Fetus is free falling into the amniotic cavity, indicating the successful procedure. Then confirmation, post reduction confirmation of cardiac asystole should be there. It is like we can see it on the color Doppler, we can see it on the power Doppler and M mode. I prefer to look at color Doppler and power Doppler also, but you can use M mode also. Color Doppler showed no flow inside the fetal heart. Power Doppler is also showing cardiac asystole. Then results of the chromosomal analysis arrived, and fetus, the affected fetus was obviously found to be affected with the trisomy of chromosome 21. and it was a Down syndrome affected fetus. But even Down syndrome affected fetus was there in the CD8 twin gestation. The another fetus was absolutely normal, and its chromosomal microarray was normal. So after reduction of the affected fetus, we continued the pregnancy till term, and healthy female child weighing 3 kg was delivered by elective LSCS at 38 weeks of gestation. So it was a happy and rewarding ending for all of us. The case two is like Primi Gravida, aged 24 years. She is married since only 1 year, non-consanguineous marriage. She conceived spontaneously. She presented for routine first trimester ultrasound scan, that is routine NT scan. Ultrasound at 12 weeks, 2 days. It revealed following these findings. The fetus was having cystic hygroma. There was a nuchal edema all over extending from head to the trunk to the lower limbs. It was having in 3D. It was having typical spacesuit appearance. NT was very high. In this case, it was 16.2 millimeters. And on further aneuploidy marker evaluation, it was having ductus venosus agenesis also, and it was having complex cardiac abnormality. On structural evaluation, the only single outflow tract was visible. And systemic evaluation, we also found that bilateral lungs were bulky, and heart was there was a mid-post heart called as mesocardia. So all these images were acquired by transvaginal ultrasound. Transabdominal ultrasound, this clarity of images will not be there, and structural evaluation would not be achieved. Like with this kind of resolution. So with all these abnormalities, ductus venosus agenesis and CHD with thoracic abnormality, lung chaos, and cystic hygroma, the more likely diagnosis was either trisomy 18 or monosomy X. Then we proceeded for the invasive diagnostic procedure, CVS, to obtain chromosomal microarray, and before termination of pregnancy, because with such kind of abnormalities, most of the time there is a tendency that fetus is abnormal, will terminate and finish off the business. But that should not be always the case, because if a microarray would be abnormal, then we can better counsel that patient for recurrence risk in the next pregnancy. All these things are going on not for this pregnancy, but for subsequent pregnancies and their outcome. So I would like to highlight, prior to termination of pregnancy, live tissue sample is always better, amniotic, be it amniotic fluid or chorionic villus sample. So always, whenever you are having opportunity, please, even if fetus is grossly anomalous, allow that for prenatal invasive diagnostic procedure. Pratna ma'am is also there. She is presenting next talk on early anomaly scan. She also will agree, and she will also vouch on that. Before termination, only invasive diagnostic procedures should be performed. So after microarray analysis, yes, the fetus was affected with the Turner syndrome, and it was having monosomy X, otherwise called as. So what this information, how this information helped us, patient, even though she opted for termination of pregnancy, but she could be reassured that it is mostly a sporadic nature of this aneuploidy, and mostly it will not recurrent in future pregnancies, and henceforth it will eliminate the anxiety about the fate of future pregnancy, that what next, how my next pregnancy will perform, and whether my next child also will be affected with the similar disorder. So that was the advantage for termination procedure. Then coming to the case 3, she is the G5, P1, L1, A3 with history of previous 3 pregnancy termination. And these are all terminations in light of multiple anomalous fetuses. Sometimes it was having intracranial abnormalities, sometimes it was having cardiac abnormalities, and so on. So on parental karyotype evaluation, she had presented at the NT scan itself. NT scan was absolutely normal, but due to this typical history, we ordered parental karyotype, and mother was found to have balanced translocation between chromosome 1 and 10. So even though nuchal translucency scan was normal and there were no structural abnormalities, but balanced translocation in the mother itself is an indication for the invasive procedure, irrespective of the first trimester normalcy of the ultrasound. After performing the amniocentesis at 16 weeks and performing early target scan, which was also normal, but amniocentesis and prenatal microarray revealed large deletion in the chromosome 10 and duplication in the chromosome 1, which was involving almost around 260 genes. So we have not evaluated which genes are involved, but these were the regions at the point where the breakpoints were there at the balance translocation. In those regions, the deletion and duplication had occurred, which was involving 260 genes. Obviously, this fetus would have been affected with some of the single gene disorders, though it was structurally normal fetus. Upon thorough counseling, patient opted for termination of pregnancy, and we counseled her that every time she has to undergo this prenatal diagnosis, because chances of unbalanced conception in cases of balanced translocations are almost 15 to 20%, and we have to offer her prenatal diagnosis in every subsequent pregnancy. This is the most elaborative case of all cases. This is obviously when we are looking at this image, I showed you the first slide image also, that this image should be looked for perfect mid-sagittal section of CRL. Nasal bone is seeing, NT is somewhat looking normal only, but we'll come to whether this is a normal image or it is a delusion of normalcy. She was the priming gravida, consanguineous marriage. She came for NT scan at 11 weeks and 5 days of gestation. She came a bit early because the parents were very anxious, because father was having muscular neuronopathy and hand deformity, and mother was having kyphoscoliotic spine. So segmental analysis after this normalcy of NT scan and aneuploidy markers performed, and scan revealed suspicion of left congenital diaphragmatic hernia. In the loop, you can see the stomach is very much seen on the left side, but heart is dextropose. Heart is pushed to the right. Though stomach is seen in the abdomen, but there is a dextroposition of heart, arising the suspicion of the left CDH. Then what next? Confirmation of suspicious anomaly should be the topmost priority, because only dextroposition without cardiac anomaly, we cannot say that this is an anomalous fetus and you can go for termination. We have to confirm that whether that fetus is affected. So at 16 weeks, there was early target scan was performed and followed by fetal invasive diagnostic procedure. Again, I'm repeatedly emphasizing on importance of the chromosomal microarray, because karyotype is absolute nowadays and microarray is primary choice for the fetal invasive diagnostic modality. As well as we have stored that DNA also after microarray, and it was followed by termination of pregnancy followed by autopsy. 16 weeks scan revealed stomach into the thorax and small intestines, and as well as part of the liver into the thorax. Superior mesenteric artery was giving upward course because bowels were already in the thorax. So confirmation of diaphragmatic hernia was done, and patient opted for termination of pregnancy in light of this anomaly. So this is the loop. Like we did amniocentesis in this procedure before termination. So, and these are the fetal autopsy images of the fetus. Additional findings which I could not find on ultrasound, or maybe overlooked upon in the first trimester ultrasound also after devoting such time. There was bilateral anochia in the fetus. Then left-sided hemidiaphragm was almost absent, and liver, bowel, and stomach was herniated into the left hemithorax and causing dextroposition of the fetal heart. Then on the stored DNA, we analyzed and we performed the genetic workup or molecular workup of the fetus. Fetus was showing 3 mutations, particularly ADNP, NRIP1, and GAS mutations. Then we tested these mutations in the father, as father was having also muscular neuronopathy, mother was having kyphoscoliosis. So we need to see that how whether these mutations are de novo or are transmitted from parents to the fetus. So ADNP was de novo mutation, which was implicated into the CDH. and father was carrying 2 mutations, NRIP1, which was associated with kidney abnormality, though he is unaffected, and GARS mutation, which is known to cause muscular neuronopathy, adult, and it is a progressive muscular neuronopathy. So at the time of birth, baby would have been absolutely fine, but as the baby grows, this muscular neuronopathy would develop. So advantages of this meticulous, extensive, time-consuming, and financial training workup in the first pregnancy. You might be thinking that pregnancy was affected, it should have been terminated and finished off. As it was a primi gravida, young primi gravida, she would have conceived next also, and we could have taken care of. But what is the advantage of this meticulous workup? That conclusive information were in our hands before planning next pregnancy. Exact recurrence of whether similar disorder will be there or not, it is known now, and need for genetic workup in the next pregnancy is well explained beforehand. There is no speculation and luck factor. We'll see. Maybe it will occur. Maybe it will not occur. But we, as a fetal healthcare provider, we should be very much sure. And when patient arrives to us, we are not there to speculate. They want definitive answers from us that whether my next child will be affected with the same or not. And for that, index child workup or present pregnancy workup is absolutely essential. Then fortunately, the couple is very much cooperative. She is second gravida at present. She is again booked with me only. So her first trimester ultrasound is performed now. No major abnormalities, but invasive fetal procedure was performed for targeted mutation analysis of these 3 mutations, and fetal microarray also has been advised. Parents are reassured that after structural normalcy, if at all genetic workup is normal, then only they can safely continue the pregnancy. And while I was refining my PPT yesterday night, fortunately that report has also come in the night at around 11 o'clock. So I was fortunate to include that slide also. And second pregnancy also is affected with the GARS mutation. As it was having autosomal dominant mutation in the father, the fetus is affected with this GARS mutation and likely to be affected, most likely to be affected with the same muscular neuronopathy which father is having. The only intention of parents was that the child should not be having any of the problem which we are facing in our life. But unfortunately, because of autosomal dominant inheritance, this mutation has recurred. Now it's up to the parents to decide whether they are going to continue this pregnancy or not, yet to be counseled. Then coming to the case 5, a young primi gravida aged 20 years, non-consanguineous marriage. She presented for first trimester ultrasound at 13 weeks, normal aneuploidy markers, and segmental analysis, structural analysis revealed this unilateral left-sided pleural effusion causing heart to deviate to the right side. So these are the loops. This is the transverse axial loop showing the left-sided pleural effusion at the 13-week scan, causing the shift of the heart to the right side. It is a massive pleural effusion, but just based upon the pleural effusion, and there was no cardiac abnormality, there was no other any structural malformation. So what next in such kind of thing? She was reassured. Fetal invasive diagnostic procedure was performed, and at the interventional procedure, amniocentesis followed by thoracocentesis to drain the effusion at 16 weeks. We again look for reappearance of the pleural effusion at 16 weeks, but when after draining the pleural effusion, this is my needle inside the fetal thorax. We drained this pleural effusion, whatever the effusion was there, microarray was performed after amniocentesis. It was normal, and at the time of anomaly scan, this is the normal fetal heart, normal thorax, and no structural abnormalities in the fetus. Pleural effusion has completely disappeared, and we could continue this pregnancy. And a healthy female child again delivered at 38 weeks of gestation. Maybe it is a coincidence, but whatever interventions I have performed, most of the cases it is a girl child. So beti bachao, beti padhao. My slight contribution to it. Again, another few disorders which are single gene disorders. I will not elaborate one by one, but these are all cases which had happened at Garbankur Fetal Medicine Center. acute tubular necrosis causing renal dysfunction and renal failure in the immediate neonatal life. Leak disease, it is kind of mitochondriopathy, which will having global progressive neurodevelopmental delay. And neuroregression, dystroglycanopathy caused by single gene mutation POMT2. It will have multiple intracranial abnormalities. Surfactant metabolism dysfunction. In this particular case, 2 of the index children were affected. The entire pregnancy was uneventful, but in first week of life, baby was put on like respiratory discomfort, put on ventilator, and typical history of some pulmonary abnormality into the index child. So we worked upon that. And congenital adrenal hyperplasia, CYP21A2 gene mutation in the index child was diagnosed. Then same was offered into the present pregnancy. Propionic acidemia, that is inborn errors of metabolism, PCA gene mutation. Sorry. Then Waardenburg syndrome, it is having heterochromia. It is again having autosomal recessive inheritance, congenital ITPS deficiency involved in intracranial malformations, congenital pseudotorch syndrome, Sandoff's disease, WDR4 gene mutation, which will be involved in mental retardation and midline intracranial abnormalities. And not to forget, most rampant and most occurring region like disorder, blood disorder occurring in our region is thalassemia and sickle cell anemia. So these are the noteworthy common and single gene disorders. Even though structural normalcy of fetus, these disorders cannot be ruled out if you are not going to work it out. And always I have put a disclaimer in my whenever the index child is affected, structural normalcy is not equivalent with the genetic normalcy. And genetic normalcy will not be equivalent with the structural normalcy in most of the opinions. So I'll not, I'll just introduce about the importance of early fetal structural survey or morphology scan, because in next talk, Ratna ma'am will be covering all these things. I'll just run through the slides. The according to this great legendary professor Bronstein Moshe from Israel, he says the probability of finding any anomaly in a low risk pregnancy population during first trimester ultrasound is 1:60 if you are looking meticulously, and probability of finding a severe anomaly at later gestation after the first trimester structural survey is normal is arbitrarily equivalent to 1:3,500. So if you are performing first trimester ultrasound in the expert hands with the meticulous invasive things, if at all any structural malformations are there, the chances of take home baby are more. And in my practice since last 3 years, whatever number I have scanned, but whenever I have done structural morphology scan in the first trimester, if it is normal, only anomalies which I have found up till now is unilateral renal agenesis in 2 of the cases and 1 ectopic kidney in 1 of the cases, where I have performed both NT scan myself and subsequent anomaly scan with me. So these are the things which should be stressed upon. So first trimester detection of anomalies, I will not be going much in detail about it, but it should be performed at 11 to 13 week scan, preferably between 12 to 13 weeks of gestation and according to protocols. Why not 11 to 12? Structural evaluation will be difficult unless and until you are implied with the implying transvaginal ultrasound into the your protocol. 12 to 13 weeks best optimal time, because fetus is horizontal most of the time. 13 to 14 weeks structural survey will be better, but there will be difficulties in measurement of NT and other aneuploidy markers. And what these are the advantages: the ability of image to image the fetus in entirety in single view, as I have shown you in the first cine loop. The lack of bone ossification, it will which will obstruct the views in the later gestation. Fetal mobility will be increased. So there would be frequent change of position, and frequently you can see that you don't have to wait for much time. Like in anomaly scan, we have to wait for half an hour, 1 hour for fetus to turn and get into proper position. But in NT scan, after 5-10 minutes or during the course of the scan, fetus changes the position frequently. Availability of high transvaginal ultrasound resolution will be most important factor. But ultrasound, I am a male gynecologist myself. In my it is very difficult to convey mother because of their religious or cultural differences. Some might have myth that transvaginal ultrasound will cause bleeding and all those things. But wherever possible, I am trying to convey the patient, because in the West it has been completely abolished. If you are not performing transvaginal ultrasound in the first trimester, then that scan is considered suboptimal. And these are the challenges in first trimester anatomic surveys. The expertise of the operator is of utmost important. Resolution I have already told, and the need to combine both transabdominal and transvaginal approach. Small size may sometimes hinder. These are the practical guidelines, USg as well as American Journal. USg guidelines were published way back in 2013. Now these are the new guidelines which have come into the picture. AJOC guidelines for routine first trimester ultrasound. They have clear-cutly mentioned these 14 planes. That mid-sagittal view depicting the CRL, then mid-sagittal view depicting the head and the upper thorax measuring NT and NB, then transverse axial section of the head demonstrating the choroid plexuses, axial section demonstrating the posterior fossa, then coronal oblique coronal plane demonstrating the eyes and ears, retronasal triangle, then 4-chamber view, grayscale, 4-chamber view color into the color Doppler, then 3-vessel tracheal view grayscale, 3-vessel tracheal view in the color Doppler, then abdomen depicting the stomach, cord insertion, bladder, to put color across bladder or not, that is individual choice, and the upper extremities and lower extremities. Open hand is very well documented into the first trimester ultrasound according to me. To get open hand in the second trimester at the time of anomaly scan is very difficult. But to get open hand in the first trimester is again very simple and faster approach. These are the standard planes which will be used, which will be covered by Pratna ma'am. And not to forget, as an obstetrician turned into fetal medicine specialist, we always have to give importance to the mother. We always have to measure mean uterine artery PI. We cannot go on fetus all the time. At the time of first trimester ultrasound scan, you have to measure mean uterine artery PI. If mean uterine artery PI is raised, you have to give a prophylaxis in terms of aspirin 150 mg OD for prevention of preeclampsia. And if at all she is willing, you can order further screening of preeclampsia, PLGF, and all the factors. So these are the challenges. This is the landmark paper for challenges in the fetal non-chromosomal abnormalities. These are the always detectable, sometimes detectable, and not detectable abnormalities in the first trimester ultrasound. Acrania, allobar, alloprosencephaly, exomphalos, gastroschisis, megacystis, body stalk anomaly, limb reduction defect, cystic hygroma. You don't have any excuse if you are not picking up these always detectable abnormalities. Sometimes detectable or potentially detectable abnormalities, yes, they can be picked in the 40% of the cases, but with the expertise of the operator, time given by the operator for the scan, and equipment use. These are the diaphragmatic hernia, bilateral renal agenesis, lethal CHD, lethal skeletal dysplasias, isolated bone shortening, facial clips, open spina bifida. And not detectable, you have to take into account that everything is not going to be detectable at the NT scan. You have to put a disclaimer, you have to counsel the patient. When they come to a expert center, they will want you to give every information in the first trimester itself. But you have to tell them that these are the some anomalies which will be picked up only at the anomaly scan and at 19 to 20 weeks of gestation. So just to finish off, why first trimester ultrasound, it is always much more than the nuchal translucency. Head and brain abnormalities can be picked up in this image. Brainstem, fourth ventricle defects, spina bifida can be picked up. Then nasal bone forehead syndromes, cleft lip, cleft palate can be picked up. Retrognathia, micrognathia, and abnormal face syndromes. Then cardiac abnormalities, ductus venosus abnormalities, tricuspid abnormalities can be picked up. Umbilical cord abnormalities, abdominal wall defects can be picked up. Urogenital abnormalities, that is kidney and bladder abnormalities, will be picked up. Spina bifida, and not to forget mean uterine artery PI. Mean uterine artery PI should be integral part of the first trimester ultrasound. Head, you can pick up anencephaly, encephalocele, posterior fossa abnormality. So I'll just run through the images because otherwise talk should not it should not be a repeated talk otherwise. This is the anencephaly, showing the absent cranial vault presented at 13 weeks of gestation, and 3D rendered imaging showing the absent cranial vault and brain tissue free floating into the amniotic cavity. This is the encephalocele, that is the defect into the calvarium posteriorly. This is the posterior fossa abnormality. Even though sometimes NT may look normal, but in reality, something is going on into the mid-sagittal section. If you look properly, this is the proper mid-sagittal section of the normal fetus. And if you look confidently, very carefully here, the posterior fossa is somewhat enlarged. And this was this was the picture at 13 weeks of normal as well as abnormal posterior fossa. There was a defect in the posterior fossa, which was again confirmed at 17 weeks. Confirmation is very important. You cannot just go on that I have picked up this and that, and just based upon those assumptions, you have to terminate or continue the pregnancy. But you have to always give time and confirm the abnormality. You may be right or wrong, but always confirm the abnormality in the early target scan period. This was the Vermean agenesis in the mid-sagittal section, which we got. Then again, this was the twin pregnancy. Fetal reduction was performed, and patient was saved from having one child with abnormality. This was the open neural tube defect. See, in most of the cases, NT can be normal. In this case also, NT was absolutely normal, but there was mid-sagittal section. If you are seeing, not that typical 1, 2, 3, 4 block structure will be seen, because IT would be obliterated. Brainstem herniated posteriorly, and intracranial lucency was obliterated. And then the need for particularly looking for the spinal abnormality. Otherwise, it is not a routine thing to pick it up. That's why it is called as potential detectable abnormality. And not all the time this defect will be visible unless and until it is at least of the measurable size. Again, this was the DCDA pregnancy. Most of the cases I am getting twin pregnancies, because these are the IVF conceived or ICSI conceived, and ICSI conceived pregnancies already have some remodeling and increased incidences of the anomalies in the ICSI conceived pregnancies. Then reduction was performed for the affected fetus, and pregnancy was continued. Potentially detectable cardiac abnormalities are atrioventricular septal defect and outflow tract abnormalities. I am also showing. All these images are taken at my center only, by me only. If you are performing meticulously, then these are the things. If your machine is optimized properly, this is the 3-vessel tracheal view, where you can see one strip red and one strip blue. So this is typical of critical aortic stenosis. If you can see here, if in this window, the flow is going only in the one chamber. I know this may be sounding difficult to you, but when you are repeatedly seeing your structural evaluation in the segmental manner, then these things will be easy to pick it up. Then this is the fetal ascites. This is the fetal megacystis. I'm not going into the theoretical aspect and how this anomalies will take place and anatomy or physiology behind it. I just want you to look at the images and say whether this image is looking normal or abnormal. This is the dilatation of posterior urethral wall, showing the typical keyhole sign. Kidneys are abnormal, hyperechoic, pelvises are dilated. And this is the most recent case where unilateral renal agenesis was picked up again at 13 weeks, 5 days of gestation. And to my utter surprise, there was small pelvic kidney also in this case. So it was not a unilateral renal agenesis, but it was ectopic kidney, unilateral ectopic kidney, and unilateral normal kidney. This was also IVF conceived, ICSI conceived pregnancy. So we counsel that unilateral renal agenesis is not a lethal abnormality, or ectopic kidney is not a lethal abnormality. If other structural evaluation is normal, anomaly scan is normal, she is continuing the pregnancy, ongoing. This pregnancy is ongoing at present. Then this is the kyphoscoliotic spine. This was the triplet gestation, and 2 fetuses were affected with the kyphoscoliotic spine and sacral agenesis. So in this case, we offered termination for both of these fetuses, and healthy fetus was continued. So take-home message: currently, timing the first trimester ultrasound according to early pregnancy or dating scan is very important in cases of IVF or ICSI conceived pregnancies, and not according to gestational age by LMP. Dating scan is very, very much important. Sometimes there is disparity of 5 days, 7 days, 8 days, 10 days, and it will make a difference when you are evaluating at the 12 to 13 weeks of gestation. So as a gynecologist, everyone performs dating scan. Whenever UPT comes positive, gynecologists scan their patient themselves. They can just write down the CRL or gestational sac diameter and all those things, and according to that scan, they can send the patient at 12 to 13 weeks of gestation. So it is it will make huge difference. Sometimes I see patient was referred at 13 weeks of gestation when in fact she is having irregular cycles. She is not having cycles which are coming every 28 days or so. Then when I am seeing the fetus is only 10 weeks or 10 weeks, 4 days, 5 days of gestation. Then I have to call her again at after 2 weeks. If dating scan would have been performed and dating would have been done properly, then these problems would be minimized, and patient should get maximum benefit out of a single scan. When patient comes to the referral center, they are coming with the huge expectation that this thing should be picked up. Everything should be picked up with the one ultrasound only. So if one ultrasound is to be optimized, then timing is essential. Doing NT alone, that is nuchal translucency alone, is not enough for first trimester ultrasound. It's high time to incorporate early fetal structural evaluation in the first trimester ultrasound along with aneuploidy markers assessment. Clubbing NT with fetal structural evaluation by transvaginal route. Transvaginal route, I am again and again emphasizing, because transabdominal will not give you resolution or the clarity. If patient is not willing for transvaginal ultrasound and anomaly is suspected, you can just put across the paper. These things will not be picked up. And so never be hesitant about asking a patient for transvaginal ultrasound at the first trimester. If fetal invasive diagnostic procedure, that is chorionic villus sampling, is required, it can be offered in the first trimester itself. Genetic diagnosis will be rapid and it can be finished earlier, avoiding all the legal hassles. Fetal reduction outcomes are way better if performed in the first trimester. Smaller the better in this case. If it is performed in the first trimester, reduction results will be rapidly improved. Then early diagnosis will eventually help in achieving better fetomaternal outcomes. And even if lethal abnormality is detected, like I have shown you in the 4th case, an invasive fetal procedure is a must for obtaining fetal DNA extraction and storage, and it should be encouraged for prediction of similar disorder in the subsequent pregnancy. And do not order non-prenatal invasive screening, that is NIPT, before first trimester good structural evaluation. I have seen cases, some like very educated patients, they themselves know, they have Googled it up, they have themselves ordered at 9 to 10 weeks of gestation NIPT, and when they had landed up at the time of NT scan, major structural malformation was detected. So it is waste of resources, waste of money and everything. I am not against NIPT. NIPT you perform for aneuploidy screening, but you perform after a good first trimester ultrasound. So if at all invasive diagnostic procedure is required, then you can skip the NIPT thing. Nowadays, marketing strategies have bloomed up that NIPT is the answer for everything. And NIPT can pick up every genetic disorder on the earth. But it is not true so. According to great Professor Nicolaides, NIPT is good for only trisomy 21. And to some extent trisomy 18 and 13. But I'll again say, if you are a good sonographer, if you are associated with a good sonographer, trisomy 18 and 13, these are the things which will be picked up on ultrasound itself. You don't need NIPT to pick up trisomy 18 and 13, because structural malformations will be very obvious in trisomy 18 and 13. So NIPT, yes, for trisomy 21, for other things, invasive diagnostic procedure is still a choice. So there are now debates on social media, FDs, and everywhere, ultrasound groups, that NIPT is going to replace everything. The NIPT definitely will replace aneuploidy screen in the near future for Down syndrome only. But invasive diagnostic procedures are irreplaceable, and they will carry their special importance in the obstetrical scenarios. So I thank you. I am immensely grateful for this man, because all the education is providing free of cost at this age also, and his passion for the fetal medicine, and all over the globe, not even a single fetal medicine specialist you will find that is not getting trained by him virtually, and he's making differences in the millions of lives of fetal medicine consultants all over the world. And to a person like me practicing in the periphery, when initially I was very apprehensive, but by repeatedly listening to his talks and all those things, that yes, things will get difficult in your initial period. People will be reluctant, people will be against these things, but slowly you have to set the trend, and then things will fall in the place. So thank you once again, Ahmednagar OBG Society. Thank you, Pardeshi sir, Mane sir. Thank you, Edikar ma'am. Thank you, Minu Agarwal ma'am, and everyone, Honorable Foxy and Office AOGS office bearers, and thank you, Varsha Dowde ma'am. Thank you so much.
Thank you, dear Prashant sir, for very detailed case-based informative talk, and also a lot of
sorry if I have exceeded the time limit.
No, sir. Thank you so much, sir. Now I would like to request our NOGS pride and dynamic personality, Dr. Varsha Dhole madam, to kindly give her expert opinion.
Yes, actually, in this case, hello, am I audible? Yes, actually.
Yes, madam. Yes, madam. Yes.
It's not me who is the expert. It is Dr. Prashant who is the expert. It was an excellent talk, Prashant. Not repented a single timing since morning that yes, why on a Sunday morning sir ne bola hai, so I have to log in. But then true to word, you have done full justice to your topic. Oh, it is an eye opener, you know. Only thinking that doing first trimester scans and doing NT is nothing. You have to treat each and every scan as an anomaly scan. You never know what you can pick up in each and every scan. And for an obstetrician, you have to be very alert, because you are the person who is managing. Though you should know when you should refer your patient to an expert fetal medicine for consultation, for opinion, right? So the way you have elaborated each and every case, and what anomalies you have detected and what next you have done, it's really very good. You've been doing a wonderful job. I can understand that you are in the periphery, but still your connectivity and the way you are following up the cases with the reports, it is excellent. I'll tell you, it is really excellent. We in Nagpur also have many fetal medicine consultants. They are just a phone call away and we can have all the data. But I can imagine being you being in the rural place, you are doing a really wonderful job. So I should say you've done full justice to it. Picking up anomalies at each and every scan is a prime responsibility of all the OBGY persons. And I think all the OBGY persons should, as a second tool, have ultrasound in their armamentarium. And yes, of course, PCP&DT is creating a lot of trouble for everyone, but I guess over the period of time, rules have been eased, and now people are getting the benefit of it. The one take-home message which you gave was a very good point, that whenever you detect a congenital anomaly, see to it that you do the chromosomal typing, the microarray, and see to it that that person gets a perfect report, so that in the next pregnancy, she will not have any problem. You know, people with BOH, they are really frustrated, depressed people. They are just shopping one doctor to another doctor because they are not getting the results. So such type of people are really benefited. And for that, it is very important that gynecologists like us should keep ourselves updated and see to it that whatever we can help the patient in a proper way. So thank you once again, Ahmednagar OBGY Society, Dr. Pardeshi sir, Dr. Ajay Mane, Dr. Bansi sir, and Sonali for giving me this opportunity to chair this wonderful session. And Dr. Prashant, you were excellent, wonderful. Thank you so much.
Thank you, ma'am.
Great, Prashant. It was very nice talk.
Thank you, sir, for opportunity.
Thank you, Varsha ma'am. I would like to request you to stay for next talk also by Dr. Pratna Sites on the sonography. And
yes,
we need your expert opinion and share comments.
I told you, sir, today I am not the expert. I am chairing. It's an honor given to me, but these people are the experts. So I'm here. Don't worry.
Yes, thank you, Varsha ma'am, for your words of wisdom. Actually, we don't have today Megha Kalampurkar madam, who was also one of the fetal medicine expert consultant at Gulbarg. She had to leave the webinar due to her personal reasons. But we have equally competent stalworthy in this field of fetal medicine. She's my very good friend, very dynamic and charming personality. So I would like to welcome Dr. Pratna Shah, who's MBBS DNB FFM. She's consultant of maternal fetal medicine at K Pond Hospital, Aurangabad. She's specialized in high-risk obstetrics and fetal medicine. Since 10 years of experience in this field, she has presented many papers and posters in state and national conferences. She had worked at various prestigious institutes at Bangalore, Mumbai, and Pune. She's first maternal fetal medicine consultant of Marathwada region, now working for more than 5 years in the region of Aurangabad. She had successfully completed 500 fetal invasive procedures, including intrauterine fetal transfusion in Aurangabad. So I would like to welcome this dynamic personality for our third lecture on approach to congenital malformations in pregnancy. Welcome, Pratna.
Good afternoon all. It's almost afternoon. And I would like to thank Dr. Pardeshi sir, Dr. Ajay Manasse sir, Dr. Sonali madam and the Aurangabad Visual Society for giving me this opportunity. Because this was a last time planned lecture, I was not prepared for the same talk that Dr. Megha was planning to give. So what I thought is, after the exhaustive lecture of Prashant, let me lighten down the things, and for an obstetrician point of view, what we can do in such cases is what I'm going to talk about, not the ultrasound approach. Because we know in Nagar already we have Dr. Kardile sir, Devtake ma'am, Dr. Nagre sir. They're doing a very good job for the ultrasound. Because I've been seeing their reports, and really good sonography reports and good diagnosis has been given by those people. So as an obstetrician, when we get this report in hand, what we can do for these patients, how we should counsel them, is what I'm going to talk about today. So let me start sharing my screen. Just let me know whether you can see this today. Can you see the screen?
Yes, ma'am.
Is my screen visible? Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. So let us start about how we are going to approach congenital malformations, because diagnosing them is not a possible thing for all the obstetricians. The fetal medicine person does that. We are doing that as a diagnostics part. But when you get a report either from a radiologist or from a fetal medicine person, as an obstetrician, what we can do, or how we are going to think about any patient that walks in our OPD, whether she is primary or multi, whether she has any history or not, how we are going to look in this particular case to think that yes, this patient may have problem. Because as an obstetrician, if we start preparing the patient mentally that there is some possibility of some problems, that will help us in the long way to build a good relationship with our patient. Because in today's era, that is a very important part of our practice, as what we talk to our patients and how we keep them prepared for what can be the possibility of that particular pregnancy. Because complications is one part which we may not be able to prevent always, but if we keep them prepared through our proper approach and a dialogue with the patient, that will help us and the patient both way. So let us see. Basically, the top outline of the talk is about in which cases are we going to suspect that there is some possibility of some malformations, when at the earliest we can find them, and if found, what we are going to do next with them. So whenever we talk about malformations, it's not only the structural part of it, even the functional problems with the baby is what we need to keep in mind when we talk with our patients. So when we look at this paper, when we look at our routine antenatal care, okay, what we do to our patients is in the first trimester, we call them once in a month. In the second trimester, we increase the frequency of visit to once in 2 weeks. In the third trimester, we increase it still further to once in a week. because what we are thinking is most of the complications do come in the third trimester. But this is what we call as a routine antenatal pyramid of care. And if we look back in the history as who was the person who devised this antenatal pyramid of care, is in 1920 there was a health minister in UK, England. He was the person that he planned this chart, that this should be the frequency of visits for our antenatal patients. No, that was not a medical person, he was just a health minister. So this is in high time that we think about this approach to our patients and stratify this in a proper way. So if we look at this paper by Professor Kypros Nikolaides, which was presented in a journal in way back in 2011, so almost 10 years ago, he suggested that let us invert this pyramid of care so that the base, the broad base of the pyramid should be at 12 weeks. That's what Prashant has told about the sonographic part. At 12 weeks, we should be able to pick up our patients, whether they are at high risk or at low risk. The patients who go in the low risk group, we can follow up them at 20 weeks and further depending on the frequency. But those who have some high risk factor, but we have picked up at 12 weeks, that those needs a specialist care. And hence the plan of action for these patients will be different. How are we going to achieve this 12 weeks is what we're going to talk about today. Very important is one needs to be anomaly minded whenever we are doing, whenever we are approaching our patients. So very important part of that is we should know in our mind. We all know what our mind knows, only the eyes will see. So our mind should be ready, our antennas should be ready to pick up any problem from the history or examination or any investigations point of view. So our strategy should always be, first of all, screening. Screening for n number of things is what we're going to do here. And then we need to diagnose, we need to confirm as what we are talking about. So screening is very important. That's where the screening part is what I'm going to discuss here. The screening covers three things. First is history, second is examination, and third is investigations. All three components have equally important role to play whenever we are talking about picking up more and more number of patients with problems. So let us talk about primigravida and multigravida. Is there going to be a difference? Yes, definitely. Whenever we are seeing a primigravida, not necessary that just because she is a primi, she is a low risk patient. No. If we look at this case, a patient who walks in with a family history, unless we sit down with the patient and ask this particular point in detail, that how are her siblings and the kids of those siblings. Now this patient had a sister whose daughter had thalassemia. Now when we dig in this history, only our patients give, because we know in generally whenever we talk with our patients, any problem is there in the family, nahi, माझ्या आईला तर आत्ता डायबिटीस झालाय, आता ती 60ला आलीये, बीपी थोडंसं जास्त असतं पण ते गोळ्यांनी ठीक राहतं. No, this is not enough for us. We need to dig in the history, and this is point which we can pick up. That yes, if her own sister has a daughter or a son with thalassemia, that child is a thalassemia major. That means the mother, that means our patient's sister is a carrier for thalassemia minor. Now, whether her husband, that is our patient's husband, is also a carrier or not, whether our patient is carrier or not, and if both of them are carrier for thalassemia, is there a possibility that this particular fetus is going to have thalassemia major? This point can be picked up even in a primi. If a patient multigravida comes with this history that yes, my first child has thalassemia major, definitely we will look into other genetic details, we will screen them. But even in a primi, we can pick this point and avoid birth of a baby with thalassemia major. If we look at the personal history, again, if the patient has any history of epilepsy, and we know that recently, especially in the corona period, the girls have been getting married very frequently at the age of 18, 17, 19, and when they get married, they don't want to disclose this history to the in-laws that yes, she's a patient of epilepsy, she was on anti-epileptic medications, just to hide the fact. Sometimes they stop the medication on their own, or they keep it hidden and they continue to take those anti-epileptic medications which are not safe for pregnancy. This can happen. Similarly, if we look at the cities, major cities, there are n number of patients who are known case of diabetes mellitus. If this patient is diabetic, if she has not taken a preconceptional folic acid, we know the risk of the fetus having structural defect is high. If her sugars are not controlled well before the pregnancy, again the possibility of structural malformations is going to increase much more. So these points from personal history will help us to pick up that this patient can have problems even if this is her first pregnancy. In case of multigravida, apart from these factors, we have to ask the details of the previous pregnancy or pregnancies. We have to ask whether any child is live or not. Because when we ask the history of previous babies, they tell us the number of those kids which are alive, and they tend to skip a child which has expired either during intrauterine demise or a neonatal death. So unless we dig in the history, they will not tell you this history. I had a patient who walked in here with her elder sister-in-law, and when I asked her how many kids she has, she said, yes, I have 3 daughters and 2 sons. And then she was not very sure about the age of the kids. So I called the husband to come in because I wanted to ask the detail of the kids again. And when the husband walks in, he told, no ma'am, we have lost 3 kids in the neonatal age. Now, this was a very significant history, but this woman was not ready to reveal that. So, unless I dig in this history, which is very important from us, for us to know whether any point we are missing in picking up the problem. So, these history we need to ask. Also, if the previous child is alive, again we need to make it a point that if the child is along with the mother, if the baby is normal or not. I had a patient who came to me at 34 weeks for a growth scan. Fortunately, I had a chance to look at the child, and when I saw the child, I could pick up that this was a Down syndrome. But the mother was not aware. For whatever reason in peripheral area, the pediatrician has missed that this was a Down syndrome child. Now at 34 weeks, what can I do? Even if I pick up ultrasonography, I will not be able to do. And we know that 25% of the Down's babies don't have any ultrasonic feature at all throughout 9 months. So it's not always the fault of a radiologist. But if we see this child, if we ask the history again to the mother, how's your child? Is it going to school? Is it studying in normal school? Is it performing well or not? Then they will tell you slowly, yes ma'am, this child has some problem. शाळेत अजून नीट शिकत नाहीये, थोडा मागे आहे. Then we will ask about the neurodevelopmental defects in the child, right? So healthy or not has to be asked properly. If there is any history of the illness, again, I had a patient who called me that yes ma'am, हमारा पहला बच्चा है जो बैठ नहीं सकता, बट स्कूल बहुत अच्छा है, बहुत इंटेलिजेंट है, सब अच्छा है. मैंने कहा बैठ नहीं सकता क्यों, कोई प्रॉब्लम है? नहीं, उसके पैर की हड्डी में कुछ प्रॉब्लम है. Then I insisted, no, you bring the child, I want to see. And when I saw, this child was a Duchenne's muscular dystrophy, which is a, we know, X-linked disease. In male child, 50% chance of recurrence. So unless we look into the baby, we will miss on the details of the history. So we have to ask the details. We have to check medical records of the previous child. Because again, in rural way, they will explain that, okay, the baby is okay, but this is a problem, mild problem. But if we look in the paper, we will see that there is something else happening with this child, right? And if this child has not been reviewed by proper authority, like in Cape Town Hospital, we have a pediatric neurologist, we have pediatric orthopedician. So what we do is we approach these patients as a team. If a family gives me history of any neurological defect, I have my colleagues next door to me whom I ask always about her opinion, what she thinks about this particular child. From a neurological pediatrician point of view, makes a huge difference rather than me sitting here as a fetal medicine and talking to a patient that this can be possibility or that can be the possibility. Also, if proper investigations have not been done on the first child, we have to make sure that those are conducted properly. Because n number of patients walk to me for amniocentesis at 16 weeks saying that, Madam, आमच्या पहिल्या बाळाला अमुक अमुक प्रॉब्लेम आहे, आता तुम्ही amniocentesis कराल का? But amniocentesis for what? What exactly are a neurological problem in the first child? Is there any genetic cause there or not? And if it is a genetic cause, is it going to recur in this fetus or not? Now, these kind of tests, they take their own time, almost 4 to 6 weeks if we need a focus exome sequencing or a whole exome sequencing. Now, at 16 weeks, if I offer the first child a 6 weeks test, and at 22 weeks, I get a report that yes, the first child had genetic problem, and then I have to do amniocentesis at 22 weeks. We know the report may take a 24 weeks further call. What we are going to do? Fortunately, we have got this advantage of 24 weeks by the government now. But that's why in early pregnancy and if possible preconceptionally, we need to evaluate such kids if they walk in to us for any opinion. And that's why we need to take these details first in the history. If there is any history of termination, again we need to insist on details of the record. Why was the pregnancy terminated? Because what happens is many peripheral centers in the second trimester, they just terminate pregnancy and don't give us detail. Or if we have a proper authority and we have terminated a patient, it is our duty to explain to our patient that please preserve these documents. This is very important because the sonography report that documented any anomaly and the termination that has been done in our center, unless the patient preserves this record for the next counselor, for the next person who is going to see the patient, it is very difficult for us to explain what was the problem, what can be the chance of recurrence. Now, here very important to tell the patient that they need to keep it, because in our social area, what happens is if the previous child is not alive, they don't keep those documents in the house. त्यांना वाटतं की ते चांगली गोष्ट नाहीये, असे कागद घरात नाही राहायला पाहिजे, कशाला ठेवायचे म्हणून टाकून दिले. So if we are doing ultrasound or if we are terminating, we have to insist that please preserve this if you want the next child to be healthy. I would like to tell one incident here. Patient was referred to me from GMC of Aurangabad. This patient was a gravida 8. She had one female child who was alive and next kid, 6 kids, neonatal deaths. The patient told me only this history. She didn't had even one paper either of a pediatrician or the person who has delivered this baby, these babies, not one paper was kept. So I have to start from zero as what can be the possible cause of 6 neonatal deaths. I asked about any structural defect, number of digits, color of the baby, any family history, nothing. All answers are no, no, no. Then finally when I asked her out of these 6, how many were girls and how many were boys, then this patient told me that, yes, madam, I am not sure how many of them were girls and how many of them were boys. Oh, there was ambiguous genitalia in all 6. Now we can start investigating from there. Fortunately, I have found that the mother was carrier for congenital adrenal hyperplasia. We know in such cases, virilization of the extra genitalia occurs, and that's why she had ambiguous genitalia. Fortunately, she was referred to me in early first trimester, so we completed her necessary genetic workup. We completed the fetal invasive test, and we could assure her before 20 weeks that this particular fetus is not going to have those problems which her previous kids had. So this history is very important. Also, specific etiology for pathology in the previous pregnancies need to be taken into account, and preconceptional counseling for this particular pregnancy has been done or not. As I told you, if the genetic tests are done preconceptionally, they help the couple to go in a long way. Because if we want to do the genetic tests in standard labs, mind you, there are n number of labs that do these tests, but because they tend to miss out on these important mutations. I had a patient whom genetic test was done outside in some XYZ lab, and when they came to me asking that we are planning pregnancy, is this adequate? Now what happens when we look at the genetic reports, we have to look for the variant that has been specified, and there are different types of variants. Firstly, we come across unknown variants of unknown significance, and the second group is a pathogenic variant. If we have variant of unknown significance, we cannot investigate in the fetus, that is prenatal tests are not to be done in such babies. So I told them, let us reanalyze your data, and I asked the lab to give me the raw data of the previous report. And then I sent to my standard lab where I do routinely these tests, and then they called me back saying that, madam, the number of genes that have been done in this particular lab are less than 50% of what we cover as the same test in our lab. So there is no point in reanalyzing this data. We need to repeat the whole test if we really want to look into details properly. Now the patient has spent some amount of money, around 15 to 20,000, to some XYZ lab, which is not a standard lab, just because they are giving the cost less. The test was done in the XYZ lab, and now when they are really planning pregnancy, they need to spend again equal amount of money for a standard lab. What is the logic of sending a sample to such lab and wasting money, because these tests don't come handy? The patient have really have to plan for genetic tests. So whenever we are asking them, we have to think about this economic part equally. We all as obstetricians know that how much we have to fight on the economic front, especially with the corona in background. This has to be kept in mind as where we are asking our patients to do these genetic tests just for the point of saving the money. Now let us talk about present pregnancy. What are the investigations that we now I have covered the history part. This is very important because History, if we missed and we are doing investigations like NT scan, and we don't know that she has a thalassemia in her history, what is the point of doing NT scan, right? So these are the tests that should be done in the first trimester whenever we see cardiac activity. Let us start from the complete blood count, glucose challenge test, infection screen, ultrasonography and biochemical screening. If you see the sequences, ultrasonography and biochemical screening are not at the top. These are the routine tests that we do, CBC, glucose and infection. They should always be offered, and that too around 7 to 8 weeks of pregnancy. How they make a difference? Let us see. Now, whenever we see a CBC report, as an obstetrician, what all of us do, even I used to do till I came across this, we look at the hemoglobin of the patient, and then our eyes straightway drop to the platelet count. These are important things for us. If these are normal, we are assured, we are relaxed. But if these are little deranged, then let us think about what complications we can have. But what we are missing here is these two very important parameters, that is Mcb and Mch. Now these two figures, if they are less than the cutoff of 75 and 25, we need to think even in a primigravida or a multigravida, oh, these two are less than cutoff. Is she a thalassemia minor? And yes, how we are going to pick up that with the CBC? No, we need to add a electrophoresis. If possible, like HIV, we can offer to our patients a universal HB electrophoresis. If not, at least we need to offer a CBC and not only hemogram. We need to look at the CBC complete report, because this comes as an automatic part of any lab that does CBC. No lab processes only hemoglobin. Always all labs give us the CBC report, and it's a printed part. So if we look at MCV, MCH, we will know immediately that she is a thalassemia minor or not, and that will help us in the further genetic tests. Also, if we talk about the sugar test, we know that risk of 5% is there whenever we have diabetes. The structural malformation risk is 5%. Also, long-term and short-term complications for the mother are there, like we know macrosomia or polyhydramnias. And not only this, but this child whose liver is exposed to excess sugar levels in utero is going to develop the diabetes early in the age. So what my sir used to teach is, suppose I have a patient who is pregnant and I have missed her diabetes because of the high sugar in the mother. The fetus in utero has been exposed to the high sugar levels, prone for diabetes. If this fetus is a female child, when she grows into adult, she is going to have one more pregnancy with her high sugar levels, and her child is again going to get affected because of those sugar levels. So as obstetricians, we are not talking only about the 9 months of this particular woman of this particular pregnancy. We are talking about 3 generations of a disease like diabetes, which we may miss if we don't do the sugar test early in the first trimester. And if the sugars are high, we can advise her for the diet, exercise, insulin, whatever required. But that has to be done in the first trimester, because we know first trimester is important from embryogenesis point of view. So we have to keep this in mind, very important. Let us talk about screening. Many colleagues of mine in Nagar had asked me to give a lecture on biochemical screening. But today, because of lack of time and because this is a webinar on USG update, I have not covered biochemical screening today, but I'm just going to cover in brief. We will have one more lecture for biochemical later anytime in future. So whenever we talk about any biochemical test, we need to understand the sensitivity and positive predictive value. These are not only the terms that we read long back in our MBBS PSM subject. These should be part of our day-to-day life, and these two will help us understanding picking up a test whenever we want to offer to it to our patient. So modalities for the screening are going to be ultrasound, and not only the first, even the second and third trimester ultrasounds are equally important in picking up congenital malformations in the fetus. If we talk about biochemical screening, in the first trimester we have dual marker, and enhanced FTS is coming up in a high way. Many labs are providing us the additional markers at cheaper rates for preeclampsia also. And in the second trimester, if the first trimester screening is missed, that means a dual marker or anti-scan has not been done, then we need to offer a quadruple marker. But already we have a report of anti-scan and double marker, then there is no logic in going for quadruple marker. We have to understand this fact very clearly. Now, in the first trimester, what is the advantage of picking up the 12 weeks part of Professor Kipros again? Is we know that there is higher detection rate because the sensitivity and the positive predictive value of all these tests are much higher in the first trimester as going to be the second trimester. We need to pick up them early, and if the patient wants termination, we all know that before 12 weeks the termination is always safe. NT identifies high-risk fetuses, as Prashant has already discussed, not only in terms of Downs but many other conditions. there is a less bonding between the mother and child. There is more privacy for the couple for taking further decisions. Ultrasound, again, we know that the person who is doing ultrasound makes a difference. There is no doubt about that. To understand the embryology in brief, in first trimester, the organogenesis takes precedence over organomegaly. That means the formation of organs is very important in the first trimester. But in the second trimester, both these processes go hand in hand. Whereas in the third trimester, the organomegaly takes precedence, but organogenesis is still going on. That means many organs like heart tends to develop till 24 weeks. Lung development starts at 28 weeks. The CNS development tends to take place at 32 to 34 weeks. So anomaly scan at 19 weeks is normal, doesn't mean the CNS will be normal at 34 weeks. That's why importance of a growth scan by a proper person. Now this is just a image to show that how much significant change in the fetus occurs during the first trimester and sudden increase because of the organomegaly in the later part of the pregnancy. As Prashant has already discussed, I'm not going to talk at all about this because that has been extensively covered. We need to understand the difference between a physiological hernia and brain ventricles, how they are seen normally. Apart from other anomalies that Prashant has covered, this is very important from an obstetrician point of view. Whenever we see a 12-week sonography report with a multiple pregnancy, we have to insist to our radiologist to give the report whether it is dichorionic pregnancy or monochorionic pregnancy. This diagnosis can take place only in the first trimester. And if the radiologist is not giving this report, then that is going to make a huge difference in our counseling to the patient as an obstetrician. Because if we have a dichorionic twin, we know that the possibility of malformation is going to increase from 1% in a general population to 2% in dichorionic, but that tends to increase to 8% in a monochorionic twin. So if I have a patient who comes to me at 12 weeks with a dichorionic pregnancy, I can offer a routine anomaly scan around 18 weeks and take the call further from there. But that is not so in monochorionic. I need to call her back at 16 weeks, 20 weeks, 24 weeks, 28 weeks, and with each time keeping in mind that this baby is at risk of developing malformation, at risk of developing TTTS. N number of other things can happen in a monochorionic twin as compared to a dichorionic. Similar role applies to a triplet and further organ. So this chorionicity can be decided only in the first trimester. So this is very important that we decide this chorionicity before 12 weeks of pregnancy. Now let us look at what ACOG has told way back in 2007. They have offered that screening for fetal chromosomal anomalies, not only Downs, other conditions also, should be a universal process. They told this in 2007. Let us start thinking about this in our day-to-day practice at least 10 years down the lane. We are more than 10 years down the lane. So universal screening to be offered. Let us talk to our patient that yes, you can do this test after the NT scan, a double marker test. Why is it so? If we put down on paper that this was offered to a patient and patient has not done or patient has missed or patient has refused, if they come back to us later on from medical legal point of view, we have put down in black and white that yes, this was offered this patient because we know that 25% of the chromosomal problems may be missed on ultrasound, will not be visible because there may not be structural defect on all of the babies. So biochemical adds to those group of patients to help us to take the screening to a better level. If we look at this chart, I'm sure Prashant must have shown, I'm not sure because I missed his lecture, but if the nuclear translucency is less than 95th percentile, this again is very important. Whenever we look at the report of the NT scan by our radiologist, we need to insist that they should give us this percentile of the nuclear translucency for that particular gestation. Because as we previously know, 2.5 was a general cutoff for nuclear translucency. That is not so. If we have a fetus of 13 weeks, 4 days or 5 days, a value of 2.5 will be totally normal. That NT is not raised for that fetus. So when a figure of 95 percentile and less is there, alive and child, that is take home baby rate is 97%. But as we increase the figure, that alive and health rate is going to drop. Not necessary that if we have suppose 95 to 99 percentile, NT value is going to be 100% abnormal. This is again very important. I will give you example of my best friend from Bangalore with whom I studied. In her second pregnancy, the NT was 99 percentile. So we did CBS, which was normal, and then She has a 3-year-old son now who is healthy and alive. So this is very important. Just because the NT is raised, that should not be an indication for termination. This is very important. Equally important part is if we have an NT which is around 99 percentile, there is no role in offering a biochemical screening. This fetus is definitely going to need a invasive diagnostic test, because till now what we were talking about was screening test. But these figures tell us that yes, now we need to go one step further for the diagnostic test. Why is it important? For 2 points of view. One is to confirm whether this particular fetus has any genetic problem or not. Secondly, if yes, let them take the further call of whether they want to continue or not. But thirdly, most importantly, is there any possibility that this problem will recur? Now, in last 3 months, I had 5 babies who were diagnosed with cystic hygroma, increased nuchal translucency. All underwent invasive test. The CVS was done, and only one of them had Turner syndrome. All other 4 had different type of genetic problems. That means we know that Turner's will not repeat. Downs, yes, there is a possibility it will recur, and the other conditions equally have some or other effect on the future pregnancies. So 5 different cases of hydrops fetalis, but all 5 with different genetic etiologies makes a huge difference unless we have confirmed before termination whether this child has genetic test or not. So even if we are offering a termination for any anomaly, very important that we need to confirm it genetically by a prenatally invasive test. Now, various genetic conditions. Suppose we have a patient who has a previously affected fetus with autosomal recessive conditions like thalassemia, what we discussed, autosomal dominant conditions like Dijk's syndrome, X-linked conditions like DMD, and various other genetic pathologies. We need to think about all these in all our patients, because unless we have the proper history, we are going to miss out on these. If we talk about Down syndrome, only the general incidence is around 1 in 800. But I will tell you, it is not so in our life. If we deliver one child with Down syndrome, that 1 in 800 figure is not going to stand in the court of law. That patient and we as obstetrician are going to face whatever music is going to be there. So these figures on paper are okay, but in our day-to-day practice, that will not be suffice. Let us look at what are the detection rates if we use one of these methods for Down screening only. NT scan picks up around 65 to 70%. These are figures as per faster trial. If we use only dual marker, we are not doing NT scan, again it is around 65 to 70%. But if we go for a combined, that is NT plus dual, we can pick up to 90% of the cases of Downs. So a universal screening as per SUG, yes, that helps us here. Now, if we look at the gestational ages again, if we do NT scan at 11 weeks and do at 13 weeks, we know that the sensitivity from NT point of view drops, but we will be able to pick up more number of other anomalies as the baby approaches 13 weeks. A dual marker again, so it is always better to offer these tests around 11 to 12 weeks, NT and double marker. So a 13 weeks time, we have less sensitivity and specificity. Just a word about prefetal DNA test and NIPT. Last week only I had visited Nagar and I had a patient who was offered NIPT where the risk for trisomy 13 was high. We know that trisomy 13 is a condition which will be picked up by a ultrasound, because these babies tend to show one or other major structural defect. So if it is not there, then NIPT is not to be offered for them, because the sensitivity and specificity of 99% is only for Down syndrome and not for other trisomies. Also, the double marker has a PAPE component which helps us in guiding about possibility of preeclampsia and fetal growth restriction, which NIPT doesn't offer to us. So replacing a double marker with NIPT there is no rule. Okay. Now, is it enough? We are done screening? No. As I told you earlier, we need to complete the molecular diagnosis. So in the first trimester, what is the modality of diagnosis? We can see nicely that that's the chorionic villi and that's the needle that is entering the chorionic villi. We are not touching the fetus. We are just collecting the tissue from here. And what are the advantages of this is we can do the chorionic villus sampling as early as 11 weeks. For example, if we have picked up a patient who is a primary or a multi with thalassemia, and then she definitely needs to undergo CVS, we can do that as early as 11 weeks, right? So first trimester diagnosis will go in a long way. What we're going to collect here is the chorionic villi, but a disadvantage sometimes can be difficulty in cytogenetic analysis, culture failure possibility, possibility of contamination with maternal cells, and risk of mosaicism, because placental mosaicism can occur in many genetic conditions. So in such cases, amniocentesis takes a precedence over CVS. You can see here it's an ultrasound guided procedure, and what we are doing here is collecting the chorionic villi. This is how the chorionic villi will look in the culture media. Now I'll show you this report of one of my patients. You can nicely see this is a fish report and this is a karyotype. Now these are different types of tests. Each patient chooses, the fetal medicine person or a person who is doing the invasive procedure will choose which patient needs which kind of test, depending on gestational age, depending on the ultrasonography finding, and depending on what genetic condition we are looking at. Like for example, thalassemia, we will not offer a fish test. There is no role of fish in those patients, or karyotype is even not required in them. But in a Down syndrome or aneuploidies, yes, makes a difference. If you see here, there are 3 dots of red color. This means the trisomy 21 is there in this particular fetus. Okay, this is a normal karyotype. Here you see that the chromosome number 21, there are only 2 chromosomes, so that all these are in pair. And the further tests like microarray and other tests also are done routinely in our patients now. Let us talk about second trimester. We know that the TIFA scan we are offering, and now the before 20 weeks, after 20 weeks part is not there, but still we have to make sure that we should do the first anomaly scan before 20 weeks. Again, because of the same reason, that if this particular fetus needs any fetal invasive procedure, any genetic test like karyotype, the report comes only after 3 weeks. If I am doing amniocentesis at 19 weeks and the report is coming at 20 weeks, it's going to make a difference bit in a counseling and further planning of the pregnancy. So better to do it earlier. This is a simple rule which was given by Professor Dr. Suresh sir from Chennai. 7+3 rule. That means these are the 7 points that we need to keep in mind whenever we are doing ultrasound anomaly scan. Also, each point has 3 subheadings under that. That will help us in picking up all possible problems. So a score of 10 by 10 can be gained if we do follow this pattern by Professor Suresh while doing a anomaly scan. Now, let us look at malformation that can be picked up in this sonography. All systems except CNS, CVS and GIT, this is very important because these 3 are still developing. As we discussed earlier in organogenesis, these 3 organs, these 3 systems are still developing even in the late second and third trimester also. So these can be, the problems of these systems can be missed. So what we are doing whenever we are talking about anomaly scan to our patient, everything is fine, काही काळजी करू नका, सगळं चांगलं आहे, and then at growth scan you pick a problem. Then the patient will ask, you told everything was fine at the anomaly scan, now that means you missed something. No. So whenever we are explaining the anomaly scan to our patient, what we need to keep in mind is this sonography is normal at this gestational age. Whatever organs are to be seen at this gestation and how they are to be seen at this gestational age are looking like that, but still they are going to develop later also. That's why we are going to offer you one more sonography later in the late second and early third trimester also. This should be part of our counseling whenever we are handing over the anomaly scan report to our patient. Now, again, as I told you, 75% of the Down fetus will have features, but not all of them. So we need to keep that in mind whenever we are counseling to our patient. That's the same logic whenever we have a child who has a first child with Down syndrome. NT is normal, biochemical screening is normal. As I told you earlier, these 2 are screening tests. These 2 can miss babies with Downs. If the family has first child with Downs, we cannot rely only on the screening test. Hence, the part of invasive test is very important in such babies. Now, point to remember here is, whenever we are looking at anomaly scan, we need to look in the percentiles in the biometry. That means when we are looking at the figure of BPD, a BPD corresponding to 19 weeks 6 days. No, that is not an adequate report. We need to insist to our radiologist that we need a percentile value. How much is the BPD? Is it 50 percentile? Is it 80 percentile? Is it 20 percentile? Why is it important? Because when we reassess this percentiles in the growth scan, that will tell us to know the trend of the percentiles. Suppose I had a patient whose head circumference was around 50 percentile at the anomaly scan, and at 28 weeks I'm seeing the patient whose HC has dropped to less than 10 percentile. Isn't it significant? But if that would have been 19 weeks 6 days and now 28 weeks 4 days, will that tell me that it has dropped? Will it tell me that this child can have microcephaly later in the third trimester? No. That's why the percentiles should be there in our anomaly scan report. This is very important. Important part of the biochemical screening, triple screen not to be offered now to our patients. We need to add the inhibin and get a quadruple marker because that has a better sensitivity and specificity as compared to a triple sonography. So this quadruple again has around 75 to 80% of the Down syndrome detection rate at a 5% false positive rate. So if we look at all the tests that we have for Down syndrome and we look at their detection rate as per FASTER trial, you see here comparably triple screen and quadruple scores much better. NT and combined has a much better as compared to a second trimester screening. That's why first trimester screening is very important. Again, as per ACOG in 2007, whenever we are offering screening tests, we should be able to offer them the invasive test also. That means if I have a patient who has a high risk double marker report, will I offer her termination or will I offer her invasive diagnostic test? The answer should always be an invasive diagnostic test. Please, please, please never ever offer for a high risk report on a double or quadruple marker a termination to a patient, because at least I get 2 to 3 patients in a month whose previous pregnancy was terminated for a high risk report, and in second pregnancy again the report is high risk. Will you offer one more termination? No, we need to do that in the first pregnancy itself. If the first pregnancy was investigated by a diagnostic test and that fetus was genetically normal, we would not have aborted at all, na? And then this pregnancy chance would not have been there for that family. But they have, what we did is we tried to save the money by not doing the diagnostic test. We have saved the patient to undergo all this process of counseling, and she has lost some money, whatever economics part in the first trimester, first pregnancy by terminating. Now again second pregnancy, a risk report has come. Now at least we need to offer them the invasive. That is very important. Sorry? Okay. Now the modality of diagnosis in second trimester, we know it is amniocentesis. Here we can see the needle is in the free pocket of the amniotic fluid, which is not having any fetal part. Sometimes we may have to go through placenta, in which cases the possibility of transplacental leak will be there, which we call as high leak. If the incidence is less than 1%, but yes, it is there. We need to understand this. We need to explain this to our patient that yes, because the placenta was pricked, possibility of some leak will be there, which tend to settle by 24 hours after the procedure. So we don't have to worry, but we need to keep that possibility in mind whenever we are offering these tests to our patients. The advantages is we can do that at 16 weeks, which is an easier technique. But the disadvantage again, because the results are available in the second trimester, risk of miscarriage is a bit higher as compared to CVS. And the risk of infection, that is chorionetis, is there because any invasive procedure will have this risk with it. Right? Let us talk about third trimester. We have various CNS pathologies, various skeletal dysplasias, various GI atresia like duodenal atresia, esophageal atresia occurring or presenting themselves for first time in the third trimester. Hence, there is a role of a detailed ultrasound, targeted ultrasound at 34 to 36 weeks. Now, let us look at this figure, a double bubble sign. Let us look at this image of the fetus showing a nicely flexed hand, where is a possibility of skeletal dysplasia is there. Lesion cephali, again, we see the anomaly scan, the brain looks like this. But at 34 weeks, if it looks like this, then we call it as lesion cephali. This sulcation and gyration has not occurred at this gestation. This can be picked up only by ultrasound, which is done at 34 or 32 weeks, not by a sonography, which is done before that, right? So this sonography is equally important, and we need to keep this in mind whenever we are talking to our patients. What is the significance of picking up problems in the third trimester? That the remaining weeks of pregnancy can be managed accordingly. Recently, for example, yesterday only we had a new verdict by the Kolkata High Court about termination of pregnancy at 34 weeks for a major anomaly. The 34 weeks is not abortion. They have used term abortion, but yes, this can be decided if we have a valid reason. Determine the outcome of pregnancy. If I pick up lesion cephali at 34 weeks, I know this child is going to have neurological defect. I'm going to sit down and talk to the patient. I'm going to involve a pediatric neurologist and explain to the family that there is a possibility that this child can have problems. This can be done beforehand, before delivering this baby only. This we can do. We are doing. Planning for possible complications with the birth process. Planning for problems that may occur in the newborn infant. For example, I had a patient who was referred to me at 30 weeks with severe polyhydramnias. When I did amnio reduction, I could pick up that the stomach bubble was absent. So it's a esophageal atresia. Then we did amniocentesis. We ruled out Downs, we ruled out other genetic possibility, and then we sat down with the family, with the pediatric surgeon, to explain that this fetus has esophageal atresia. That means this baby needs to be delivered in a tertiary care center. This baby definitely is going to need a surgery on day 1 of life, because we don't want to pick up this condition after birth with meconium aspiration, that oh, the 3-tube pace is not working. No, that's high time now that we pick up ourselves with these conditions earlier in pregnancy only. And this patient delivered at 2 o'clock in the afternoon, and the baby was on table in the OT at 5 o'clock. By 9 o'clock the surgery was over. Next day morning this baby was off venti. This is how we are going to manage our patients if we are able to pick up these conditions even in the 3rd trimester. Okay. Also, the finding conditions that may affect the future pregnancies can be done if we do a proper targeted scan at this gestation. So the take-home message here is going to be: if previous pregnancy is terminated due to anomalous fetus, early anomaly scan at 16 weeks should be offered. Routine interval growth scan around 28 to 30 weeks is very important. A good sonography again at 34 to 36 weeks before delivery, and use of fetal invasive procedures, either a CVS or coronary amniocentesis, whenever needed to complete the diagnosis, should be offered to our patients. Thank you all, and I wish all of the obstetricians attending this webinar a happy journey on the tough road of obstetrics in the future. At the end, again, I would like to thank Dr. Ajay Manasse sir for giving this opportunity, Aurangabad OBGYN Society, Dr. Pardeshi sir, Dr. Sonali Vadne madam, Dr. Bansi Shinde sir, and Nagar OBGYN Society for giving this opportunity for a wonderful time with you. Thank you.
Great. Thank you, Prarthana. It was a great lecture. And it was not 11th hour, it was 12th hour basically. But you accepted it and played it very well. Thank you. Thank you very much.
Yes, thank you very much, Dr. Pratna, for accepting to speak on the last hour. And that too, it was such a wonderful and excellent talk that we all were lost completely, like this road, you can say. So it was really very, you can say in detail, it was explained, and it was really very wonderful listening to you. Though
Thank
it was
you,
Sunday and our leisure time, we really had an academic feast listening to you.
Thank
So
you.
now I would request our chairperson, Varsha ma'am, to kindly throw some light.
Yes, I must say, I must congratulate the Ahmednagar OBGYN Society for having such gems in your society. Yes, ek se badkar ek. Very good. Prarthana, I was mesmerized. Mala asa vatla, I'm sitting in a class and my teacher is teaching. You know.
Thank you.
Very nice. The way we like explain to the patients, and then the way we like talk, la, ye, hey, dhalas paije, hey, khela paije. Why are these people doing like that? Wonderful. Hope must sir. So proper history taking and giving proper inputs to the patient and counseling forms the primary basis of our practice. We basically are OBGYN persons and then into fetal medicine consultants, or maybe we have radiologist counterparts with us. But then, yes, the onus and the responsibility of the patient's obstetric career always and always lies on us as primary consultants. So that was wonderful, and really thank you for that 12th hour acceptance of the talk. And it was very good to listen to you.
Nice to have these words from you, ma'am. Thanks a lot.
Vidya ma'am, share your comments. Dr.
Yeah,
Vidya.
it was really excellent to listen to you, Prarthana.
Thank you, ma'am.
Yeah. And those case discussions and how you approach and how to counsel, that is really art. And I think many things to learn from you.
Ma'am, I would like to tell you here, I'm a student of Dr. Prakash Mehta. So I learned this from him.
Okay.
I did my DNP with him, so a lot of part from his, medical legal aspect approach makes a difference in our practice also.
Yeah. I would love to be invite you in my society also sometimes. So I'll
surely, ma'am. Sure, it will be great honor.
नाही ते मला सांगायला लागतं पहिले मग मी निरोप देतो त्यांच्याकडे.
बर.
Thank you, sir.
Thank you, Vidya ma'am. Do we have Meenu ma'am here?
Meenu is there. I think she is on board. I think we have to call her because imaging chairperson has to comment on that. I think I'll call.
Bansi sir can give comments. Bansi sir.
Ajay, can you call Meenu? can talk.
Yes, I'm calling.
Bansi sir.
Rajendra sir, actually, all the talks were excellent. Pratna ma'am, as Manasse sir told, she was a speaker of 13th hour and very well covered. She definitely added to our knowledge, and all the topics were very well covered. And I think it will be helpful to all the participants, and definitely it will help them practically also.
Yeah, Dr. Minu is not picking up phone, I think, and she must not have listening to. So, Pardesh sir, can we end the session?
Yes, you can end.
And and from my side, I tell you all of the faculties and delegates, Prarthana is a hardcore teacher. She teaches to patient also, because I have sent so many patients to her. Even my near relatives went to her, and she was counseling like that की नाही हे असंच आहे असंच आहे असंच आहे आणि हे अरे म्हणलं तू पेशंटला कुठे शिकवते, but she is hardcore teacher. She teaches patient also. So great person. Over to you, Sonali ma'am.
I think sir, Rajendra Pardeshi sir was giving some closing remark, sir.
Yeah, and I must congratulate the other two speakers also. This Dr. Prashant was also, his talk was very excellent, and point-wise, he discussed how to do all those interpretations and all. So that was a really excellent talk by him, and I think Ashwini has left, but my so many postgraduates and so many colleagues have joined, and they also appreciate Ashwini's talk also. Basics of IU and what should be done and what should not be done. So that was also excellent. That's what I wanted to, because I talked about only Prarthana, so I wanted to comment on the other two speakers. Thank you very much.
Congratulations, Dr. Bansi, Dr. Sonali, and Ahmednagar Obituary Society. It was really an excellent webinar. All three speakers were nice. Ashwini has explained very nicely to improve the IUI results. And Prashant and Prarthana, they are the teachers from our society. I'm telling you that. Exactly. And Vidya ma'am, you can call them for your Kasoga. They can conduct whole workshop. These two only persons. And see, they are star from our Aurangabad Obituary Society.
पण ते परत माझ्या थ्रू जावं लागतं.
Thank you.
हे 30 मार्च पर्यंत माझ्या थ्रूच जावं लागणार आहे तुम्हाला. गमतीचा भाग सोडा. खूप छान शिकवतात सगळे. आमची मंडळी फार भारी आहेत.
Over to Sonali.
Yes, sir. So on behalf of AOGS, I would first of all like to thank AMOX for organizing educational webinars to enrich our knowledge. I also thank our enthusiastic convener, Dr. Ajay Manasse sir, our chief guest and great teacher, Dr. Kanan Yelikar madam, Dr. Rajendra Pardeshi sir, Vidya ma'am, and Minu ma'am for their gracious presence and their encouragement. I also take this opportunity to thank our chairpersons, Dr. Dowle madam and Varsha ma'am, for all their good words of wisdom. It's also my great pleasure to thank our eminent and lucid speakers, Dr. Ashwini Kare ma'am, Dr. Prashant Asegaonkar sir, Dr. Prarthana Shah, the last moment speaker who was really very excellent as usual. I also thank our president to take lead, Dr. Bansi Shinde sir, for organizing today's webinar. Finally, I also thank our educational partner, Shield Healthcare, for their assistance in organizing and execution of today's webinar. Finally, I would like to thank all the participants who spared their leisure time on beautiful Sunday for our educational feast. So thank you one and all, and good day. Have a nice, relaxing